Bom, boa tarde, good morning, good afternoon.
Good afternoon. It's a great pleasure that I start today the international series of webinars, starting with the topic, the use of self-test in fighting COVID. This event is the result of a big effort that the London School of Hygiene and Tropical Medicine and International Diagnostic Center is been doing and promoting for a while now. In this sense, LADIV, the Latin American Alliance for the Development in Vitro Diagnosis, with FIND, the Foundation for Innovative Diagnosis, got together and had a wider discussion, and with the support for the COVID-19 Convergence Project, the MDRC, that has the support of USAID and ANS. There are a lot of partners, CBDL in Brazil, and AudMed in Latin America, the Alliance for Medical Devices. All of them with the same goal of bringing more tools in fighting COVID. COVID that is a ghost that's hunting us for more than 2 years, that killed a lot of people. So for you to have an idea, Brazil recently released in the Institute for Research a report that shows that in 2 years, from 2019 to the end of 2021, 4.4 years of life expectancy of the Brazilian people. So that before was 76.6 years, it dropped to 72.2 years old. This is scary. It's going to bring huge impacts for economical activities, for retirement, and we're going to have a lot of issues regarding economy, social areas, and other consequences. A lot of births were delayed, pregnancy that didn't happen, and all of that, also the chronic diseases that were not diagnosed or were not being monitored in the proper way. The diagnosis market needs to be available for the population in the different fronts. And this is going to allow us to get a recovery. COVID as a pandemic didn't end, and now we'll debate in this first session, and we are going to continue on day 7 next week, the second session, with a lot of experts from around the world that will bring their view, their experience, the technical view and experts to add value in this fight. In this moment, and I will end my thinking, that we need to get your attention. It's not because we are not using masks that the other proper cares shouldn't be done. The two for diagnosis is important. We have 1.6 million cases of contamination a day, against a peak that we had 3.8 million in January, and an average below 892,000 infections during the 2 years of the pandemic. So the problem is still there, and we have new variants that are appearing all the moment. So the first session, I will invite Professor Rosana Pilling, that's professor and director from the Diagnostic Center and Research from the International Diagnostic Center, and London School, Hygiene and Tropical Medicine, that it's going to do the first presentation. And here, that was the key that was missing, the use of self-test in fighting COVID-19. So Rosana.
Thank you so much, Carlos. And I really like to say that this has been a really productive collaboration that we had with you in the last 10 years in terms of doing these series of international webinars and seminars and workshops in order to tackle the issues about diagnostics at whatever time it was in the the topic of global health. And here today, I just want to start by putting into context the use of self-tests in the fight against COVID. And here we have just from the 27th of March, where we are today with regard to the pandemic. And you could see that in essence, this has been a very, very long pandemic. Most of us in the beginning thought it would just last one season, and that by the summer, the whole thing would be over. Little did we know that 2 years later, we're still trying to control the pandemic. And so just in the context of how to use diagnostics during this pandemic, we've really evolved to our thinking around what we know about the virus, since this is a new pathogen. Now, at the very beginning, when the Director General of WHO, Dr. Tedros, started to announce that this is a pandemic, he did also say that he urged countries to test, test, and test. And he said testing, isolation, and contact tracing should be the backbone of this pandemic. So you could see on the right-hand side, many countries have set up special testing centers, either as temporary tents or actually special places in the hospitals for testing. And so in terms of the use of diagnostics in the first place, we wanted to use it to confirm the clinical diagnosis of symptomatic individuals. But at the same time, because we know so little about the virus, we wanted to use diagnostics to look at refining the case definition for COVID. And of course, testing of contacts to interrupt transmission and enable research to determine the mode of transmission, the speed of transmission, and monitor whether any interventions work or not. But very soon afterwards, by March and April of 2020, we know from contact tracing studies, from case histories, that asymptomatic individuals can also transmit in the community, as well as pre-symptomatic. That means before they become symptomatic, people were already shedding virus and therefore able to transmit their infection to others. So with that, the entire premise of using testing only for symptomatic individuals has now gone by the wayside, because we now know that studies show that between 14 to 50% of infections in communities could be due to asymptomatic or pre-symptomatic transmission. And with that, some countries consider mass testing, more consideration of using less expensive or less demanding tests, such as antigen detection, in order to try to screen for people who may be at risk of acquiring infection or transmitting an infection. And at the top of that list would be people who work in hospitals to care for COVID cases, or people who work in elderly care homes who may be putting their care home individuals at risk if they are positive. So it's really important that we think of, in the first instance, only using molecular tests to confirm cases, but then with the second phase, when we know about asymptomatic, pre-symptomatic transmission, that's when we first thought about using simpler tests that can be accessible in communities to screen for population at risk. And then, of course, with March, a lot of countries started to lock down. And so testing for travel, it becomes very important. And testing for travel at that time usually is only restricted to using molecular tests because they're the most sensitive. But some countries where molecular testing is hard to come by, or that the results way too long, some countries would allow antigen testing. Now, as the epidemic went on, in that same year, we now know that they're starting to be variants of concern. At first, they were variants of interest. We're watching how well they develop, but then it became very apparent by September of 2020 that there are a number of variants that are very efficient in terms of transmission, and also the speed of transmission became very important. And so when you see, for example, the Delta variant that was first detected in India, we could see that rather than having an incubation period of 7 days or so, where you could see that you do have that time for contact tracing, you no longer have that luxury. With the Delta variant, I remember the public health in Singapore, they looked at their contact tracing records for the Delta variant, and they could see that there were 3 generations of transmission within as short as 10 days, which means that the top-down approach to using identifying cases and contact tracing are now no longer possible. So with that, we come into the phase of the epidemic where we started to look at variants of concern, how to monitor these variants of concern. And because vaccines have become available, maybe testing of individuals would be less in demand as we ramp up vaccination. But nevertheless, vaccines don't prevent infection. They prevent the hospitalization and they prevent deaths, but they don't prevent infection. So we do have a race to try to keep up with the variants of concern. And that's when many countries started to think that self-testing has to be the option, because top-down approaches for tests and contact tracing are no longer possible. Now, so one of the first countries to approve self-tests is the United States. So in November of 2020, the US FDA granted the first emergency use authorization to the first COVID home test. And in January of the next year, the White House put out a statement to say the testing is an important tool to help mitigate the spread. And that the CDC has recommended the use of at-home tests if people begin to have symptoms or are gathering indoors with a group of people who may be unvaccinated or at risk of severe disease, such as those who are immunocompromised, etc., or have underlying comorbidities. Now, to date, in the US, the FDA has granted EUA authorization for 15 rapid antigen detection tests and 3 molecular tests as home tests. And they're widely used, and they're available from pharmacies and from testing centers. Now, in the UK, in December of 2020, the UK approved its first COVID self-kit. And then in March, the UK government decided that employers in England will be able to offer free rapid tests to their staff to take home to test. And that's because if people are positive, but they have to travel to work to find out that they are positive, then they've already infected people that they are in contact with on public transport, going to work. And then they still, after they test positive, still have to travel back home. So the wiser thing would be to offer the free test for staff to do at home their tests before they come to work, and only come to work if they're negative. And so that was offered on the 28th of March, and quickly 60,000 companies have signed up for this workplace testing. But then by April of 2021, the government has decided they will give access to 2 rapid tests a week from that Friday for everyone, and that the test would also be freely available and for free at testing sites, pharmacies, and throughout the post, the mailing system, if you want to request it. Now, interestingly, in April of last year, the health secretary said that this will help squash any outbreaks as lockdown eases. But critics of the program said it risks becoming a scandalous waste of money. So I think that everybody has a different opinion about self-tests in those early days, about a year ago. And what is it today? So today, here's something from the UK Health Security Agency. And they showed in numbers how many tests have been used since the beginning of the pandemic. But of course, that's not only self-testing, but there are, to the right-hand side of that picture, is 7 million tests available through their home delivery channel every single day. And so that's in the UK. And when I was last in London, I see that people test as part of their social lives before they visit the elderly relatives, before they go to a club, or after they come back from a club. And they freely share with others their status. You know, if they tested COVID positive, they were not hiding the results. They share it with their friends and say, sorry, can't over, tested positive, etc. And so this has become part of their social fabric right now. And in fact, we went to visit a friend, an old friend from Canada. And when their son came home for Sunday dinner, their son had to be tested before he could sit down for Sunday dinner, because he goes clubbing with his friends, and his parents were concerned that he would spread the infection. And so that's become part of our normal living. Now, as to whether people actually upload their positive results or negative results to the government website, apparently only a small fraction would do so. Now, in the rest of Europe, starting from March of last year, the European CDC already published a statement to say that self-tests improve the accessibility to testing and support the early detection of cases and can reduce the risk of community transmission. And they said now that at that time, they wanted to say that shifting the responsibility of reporting test results from health professionals and laboratories to individuals could lead to underreporting and make measures such as contact tracing, quarantine of contacts more challenging. Now, what they didn't say was that actually also the quality of tests and quality of testing has to be considered, and also the risk of positive and false positive and false negatives. Now, in the following months, in April of 2021, the Swiss government decided that rather than leaving it for the individuals to try and seek the test, self-testing online, because there are a lot of very not very good tests that are being sold over the internet. And so in order to control the quality of the tests that people use for self-testing, the government decided to allow everybody to obtain 5 self-tests per month free of charge from a chemist. And so in a way, try to control the quality of the tests that people use. Now, in Singapore, and Singapore being a small island nation, has a very tightly controlled epidemic. And they first approved their self-tests also in May. And now 16 different test kits have been granted emergency use authorization. And also in August of last year, every household in Singapore was entitled to self-test kits. And the the Ministry of Health actually said, and this was reported in the Straits Times, which is a major Singapore newspaper, as Singapore, the Ministry of Health said, as Singapore gradually transits to being, being a more resilient nation, and the society will have to play an important part in managing the pandemic, which is a concept that many of us are starting to realize that in the past, when we talk about public health, we tell the public what needs to be done. But in this pandemic, we realize that a new definition of public health has to be that we empower the public to, with the knowledge and the tools, to do their part in the public health response to a pandemic. And that's really important. And we could see this playing out in some countries better than others. And having that personal responsibility for your health status and the safety of others around you is something that I think most people would take seriously, and therefore self-testing can be a viable option for pandemic response and control. Now, to date, there are over 100 countries that have approved self-testing. And we could see that you could use this test as a test to protect the vulnerable, as a test to release from quarantine or self-isolation after testing positive, as a test to stay in school or workplaces, as a test to enable the resumption of mass gatherings and travel in order to allow the economy to recover, and also a test to empower individuals to take responsibility for their own health and take a part, an active part in the public health response. And of course, underlying all this, as I've said before, our concerns are the quality of the tests that they buy, or being given the tests, the quality of the testing. Even though many test kits come with video instructions as well as written instructions, but there are still concerns about whether there are mistakes made and whether those mistakes translate into a wrong test result. And I think this is something that would be discussed later. And then there should be risk mitigation strategies for false positive and negative results, reporting of cases. How do we do that now with self-testing? There's fear of coercion and unintended consequences. But I think that these concerns will be what will be addressed by the WHO guidance on self-testing, which will be the next presentation. So thank you very much for this opportunity. Thank you.
Fantastic, Rosanna. I do appreciate your kindness and always being present, especially when Brazil is concerned. We have been counting on you for all these years. Thanks a lot. I'd like now to invite Dr. Gillian Sachs. She's an immunologist with expertise in infectious disease diagnostic, product development, introduction, uptake, and scale up. She's currently a technical officer in WHO's COVID-19 health operations laboratory team within the health emergency program. Gillian, thanks a lot for accepting this invitation. We are honored to have you here, and please take the floor.
Thank you so much. Can you confirm that you see my slides in presentation mode? Great.
Yes, perfect.
Well, thank you so much for the invitation to join this webinar today. I'll be providing a little bit of an overview on the self-test guidance that WHO released about 3 weeks ago. So as a bit of context, obviously since the start of the pandemic, WHO has been releasing guidance and operational materials to support SARS-CoV-2 diagnostic testing, recognizing that timely and accurate testing is an essential part of a comprehensive COVID-19 response strategy. This started back in early 2020 with the release of our first guidance on laboratory testing for SARS-CoV-2, which really gets into the details on the different technologies available for testing. Later in 2020, we first released interim guidance on the use of antigen detection tests in the diagnosis of SARS-CoV-2. And that guidance was most recently updated in October of last year. We also have guidance on how national programs can consider setting strategies to guide their testing programs. And all of this is underpinned by supportive materials, including implementation guide that was developed as a collaboration between FIND and WHO, as well as 2 open WHO courses, one that gives an overview on antigen rapid testing for SARS-CoV-2, and another that specifically talks about implementation of these assays. And then, as I noted, our most recent guidance was released about 3 weeks ago on the use of SARS-CoV-2 antigen rapid tests specifically for COVID-19 self-testing. We also are trying hard to digest and simplify our somewhat dense guidance into infographics so that we can enable support for testing at both the individual level as well as at the community level. And I've included links here to several of these infographics. So I will note that obviously throughout this pandemic, there are different waves and different forces of infection that are driving changes in testing rates. And each country is really facing a different situation at different times. And it requires being very agile and thinking through how you implement your testing strategies. As the pandemic continues and the virus continues to evolve, we recognize that policy adjustments will be needed. And so we try to make our recommendations and our guidance to be flexible so that it can be adapted as per national context. So when it specifically comes to the use of antigen tests for COVID-19 self-testing, this guidance was issued by WHO on the 9th of March. It is similar to other WHO guidance. It is driven by the evidence. And our guideline development group specifically focused on the fact that there's data to show that users can reliably and accurately self-test, that COVID-19 self-testing is acceptable and feasible in a wide range of settings, and that it may reduce existing inequalities in testing access. We recognize, though, that self-testing is only one option, and therefore this guidance is meant to be considered in conjunction with our other guidance, especially our most recent guidance on the use of antigen RDTs by professionals. The intended audience for this guidance document are policymakers and others who are responsible for planning and implementing SARS-CoV-2 testing, especially in low and middle income countries. And we are working to make derivative products that would be more targeted for the public who would be end users of self-tests. So the recommendation that was set by our guideline development group is that COVID-19 self-testing using SARS-CoV-2 antigen rapid tests should be offered in addition to professionally administered testing services. This is a strong recommendation, meaning that most countries should adopt this policy. And it was based on low to moderate certainty of evidence. In the guidance document itself, and I have the link here for you, we make remarks specifically around human rights, around the evolving epidemiology and context in which self-testing would be implemented, highlighting the need for national programs to think about how to prioritize this intervention and the appropriate messaging that should be used given the local context, as well as the need to continue to monitor the accuracy of self-tests as well as other tests as new variants emerge. There's also implementation considerations, specifically touching on results interpretation, messaging and support that should be considered by national programs, service delivery options, as well as reporting. I'll just highlight here the different evidence sources that were used for this guideline update. So there were 2 systematic reviews of the preprint and published literature, one on the accuracy and reliability of self-tests, and the second on the impact and utility of self-testing. We also commissioned a global survey of the public on existing policies and extent of implementation. And then we also reviewed data from a UNITAID and FIND supported feasibility and acceptability study that took place in Malawi and Zimbabwe, as most of the published literature comes from high-income countries at the time. Finally, we reviewed survey responses from the general population, healthcare workers, and potential implementers of SARS-CoV-2 testing across 8 low and middle income countries that was conducted by FIND. So some of the key points from the guidance is that self-testing will need to be adapted to the national priorities, epidemiology, resources, be that financial as well as human, and the local context, and that this should really be with input from the community in which the testing is meant to be implemented. We recognize that the populations that may benefit from access to self-testing will vary widely by setting. And so it's really important that programs and implementers review their national context and that community engagement happens so that there's appropriate participation and planning as part of these rollout of these interventions. We also note that self-testing really should always be voluntary. And it's important that in certain settings, such as schools and workplaces, that the costs of self-tests are not borne by students or workers. Clear messaging is really needed so that users understand when and how to self-test, what the meaning of their result is, and what they're supposed to do following a positive or negative or invalid result. Finally, we note in the guidance that self-testing can be considered both for diagnostic as well as screening purposes. So what this means is that depending on the epidemiological situation, someone who is symptomatic or someone who knows that they had a recent exposure to SARS-CoV-2 because perhaps they're a contact, they can consider a positive self-test result as a diagnosis of SARS-CoV-2 infection and should link to care and access to therapeutics as appropriate. Self-tests can also be considered more for screening purposes. This would be for someone who may be asymptomatic, who has no known exposure to the virus, but maybe just wants additional reassurance that they are negative in order to engage in a particular activity. In that context, you might want to consider confirmatory testing for a positive result because the positive predictive value may be a little bit lower. In the guidance, we do include implementation and monitoring considerations. And I will note that WHO and FIND previously released implementation guidance specifically on SARS-CoV-2 antigen detection rapid tests, and many of the same principles that are considered for the rollout of professional antigen tests are applicable to the rollout of self-tests. We note that self-tests should meet existing standards for professional use antigen RDTs, meaning they should be at least 80% sensitive and at least 97% specific when compared to a nucleic acid test comparator. And we also note that in the studies that we reviewed, many of the self-tests meet the sensitivity requirement, especially among symptomatic individuals, and exceed the specificity requirement. So they have at least 99% specificity or higher. We note that it's important that storage, operation, and disposal information needs to be provided, and it should be possible to throw away self-tests in the general waste system. It's important to adapt existing quality assurance procedures so that they can include self-testing kits. As Professor Peeling noted, we want to ensure that the quality of testing, even though it is by the general public, is maintained. And that it's really important that resource requirements and systems for the procurement, the distribution, stock monitoring, consumption tracking, et cetera, of self-tests needs to be considered as part of overall testing systems. And as noted previously, programs should review the role of self-testing within their overall programs and adjust implementation and messaging as needed. We also noted that there are digital tools available to help capture test results or enable reporting, but these need to really be appropriately planned and adapted to the needs of end users and may or may not be appropriate in every setting. There's additional context in the guidance noting that while data visibility may remain a limitation of self-testing, the increase in access may far outweigh that concern. So I will just also note that we have more and more therapeutic options becoming available for COVID-19, including oral antivirals, which are starting to become recommended and available globally. Many of these need to be administered early following symptom onset, and so increasing timely access to testing is really essential. And hence the use of antigen tests by individuals through self-testing, as well as by trained professionals within the healthcare system, really can improve early diagnosis and earlier access to the clinical care pathway. When it comes to improving access to reliable and affordable tests, we note that self-testing really provides a way for people to test and make personal risk decisions. We recognize that there is increasing availability of these self-tests, but in many markets, these remain in the private sector, and hence prices remain out of reach of most, especially individuals living in lower middle income countries. In order to address some of this, WHO has now opened our emergency use listing procedure to review self-tests. I've included the links here where you can see what the requirements are. And hopefully this will facilitate access to quality assured and high performing self-tests in the global market. I will note that WHO has been a bit slower in coming up with our guidance related to self-tests, and hence our pre-qualification colleagues are using an abridged assessment for products that have already been approved through the EUL procedure for professional use, or products for self-testing that have been approved or authorized by the US FDA, Health Canada, or the Australian Therapeutics Goods Administration in an effort to hopefully enable expedient approval of self-tests through the emergency use listing procedure. I will finally note that one of the sources of information that we used to set this guidance was a global survey. In that survey, we found that over 100 countries are already either implementing self-testing, piloting self-testing, or are in the process of developing supportive policies for the use of self-tests. But we did note that the reach of self-tests seemed to be already greater in high-income countries than in low and middle-income countries. And we're hoping by having this guidance, we can help facilitate a more equitable balance in accessing self-testing. Many respondents reported that self-tests are distributed through pharmacies and retail settings, in addition to community settings and other clinical settings. There was high willingness reported to use self-tests across all 6 WHO regions. And as already pointed out by Professor Peeling earlier, there are many self-test products available, many of which are of questionable quality assurance or regulation status. And this supports the rationale for why it is critical to enable WHO EUL approved products. So I think with that, I will thank you very much for the invitation to present today. Back to you, Carlos.
Thanks, Gillian. It was great. I have one question before passing to Cheryl. I realize you have already printed and actually distributed a PDF version of the English guidance. Are you preparing a Portuguese and Spanish version, or would it take too long? And if so, could we start working on a non-official Portuguese and Spanish version here for Latin America?
So we are in the process of translating the guidance into all 6 WHO official languages. Portuguese is not one of those, Spanish is. But we will work with our PAHO colleagues likely to have a Portuguese translation, but if we have any issues with that, I will follow up with you.
Yeah, no, that's great. Count on us for facilitating and expediting that.
Perfect.
Thanks a lot, Gillian. I will now ask Cheryl Johnson, Technical Officer in the Global HIV, Hepatitis, and STI programs, working on self-testing for over a decade, covering guidelines, country support, and research, to conduct a debate a discussion with you, Jillian, Rosanna, and all the other speakers that are here are free to take part as well. Cheryl, you have the floor, please.
Excellent. Thank you so much, Carlos, and thank you, Rosanna and Jillian, for great presentations. I really want to, encourage folks to write any questions they might have in the chat so we can, take those forward in this session. But one thing I wanted to ask both of you, at the beginning of Rosanna's presentation, she talked about the early advice from Dr. Tedros to test. Given where we are in the current, pandemic and with the self-testing guidance now out, what do you think is really the best way to operationalize that advice with what we know now and where we're headed in the COVID-19 pandemic and with self-testing? So I just want to open it up with what your thoughts are now moving forward.
Jillian, you want to go first or shall I?
Please go ahead, Rosanna.
Okay, so Cheryl, thanks for that question. It's very important because many countries are now thinking, okay, if people are not ready to report or too busy to report or shy to report their either positive or negative results, then it would be difficult to know where we are with regard to the pandemic and when is it ending, right? And so many countries have switched now to relying more on wastewater surveillance to look at how communities are doing in terms of having traces of the virus in the community. So for those who are not familiar with wastewater surveillance, it's actually looking at sewage and looking at whether there are fragments of RNA still left. So it could be a long tail of positives, but I think over time, you may be able to see a trend of decreasing viral load in sewage, which means that as a community, the pandemic is receding, right? And so rather than relying on case detection, the way that we've been doing, waking up every morning and looking at the numbers of cases, we can no longer do that, okay? And so that's another alternative. And it's the evolution of testing strategies as we are now facing. Jillian, over to you.
Yeah, thanks, Rosanna. I agree wholeheartedly. I think there's two aspects that are happening here. I think testing remains really critical for giving visibility into the evolution of this virus globally as well as locally. But as Rosanna pointed out in her presentation, testing is also becoming part of personal choice and empowerment. And I think as we move forward, I think it will be up to countries to figure out the right mix of ensuring that testing is accessible to anyone who needs it, but also maintaining appropriate surveillance so that we can ensure that medical countermeasures are available to those who most need it, so we can adjust our public health and social measures as needed, et cetera, and be as agile as possible. So I think it's overlaying that baseline surveillance where we want some level of representativeness of high quality testing, whether that's through wastewater surveillance, whether that's through sentinel surveillance, et cetera, and then also enabling individuals to have choice in accessing testing so that they can engage in activities as appropriate and then seek care as and when necessary.
Yeah. And this would be more important in cultures with multi-generation homes, right? That individuals would want to ensure the safety of their elderly that are living with them. And so those are part of the personal choice and protecting vulnerable individuals in the community.
And also, if I may complement, we have also the issue of first stopping the circulation of the virus, so as early as possible to interrupt the disease to be continuing. That's one. And second, really to promote the early access to therapies. That's a very important thing. So some people in a large country like Brazil, 8.5 million square kilometers, not everyone has immediate access to a lab or to a hospital. They would take long time to get there. If they have available a self-test, they immediately know, and through telemedicine and other IT technologies that we have now available, you can really secure a kind of therapy for that person.
Mm-hmm. Yeah.
And Carlos, just maybe to follow up on those really helpful remarks and insights, particularly with Brazil, when you have a municipality, driven kind of health system with different policies in different locations, when you think about the applicability or what it's going to look like now to implement testing and self-testing, what is the mix of public and private sector engagement that you see, and what kind of actions are needed at the global, regional, and local level to support countries like Brazil around testing?
Yeah, fantastic question. Thank you, Charu. What I see is that you must have a combination between public and private, first point. Second, even within private or public, you must have also a combination of the different tools that you have available in diagnostics. So we're talking about professional RT-PCR, professional rapid tests, antigen, eventually antibody, and especially the self-test. For instance, in a small community where you have an outbreak of COVID, it doesn't make any sense to keep people waiting hours and hours online there outside a building in order to get a test, to have a test deployed. And that's exactly the image we saw. It's reality in January. In January, Brazil had an outbreak, a combination of H1N1 or H3N2 plus COVID. So many cases, and were one or the other. And people were looking for labs, public or private, and were standing in line. That's summertime. So it was going to rain anyway, and most people would or go back home, give up testing, which is a problem, or would all go inside in a small facility, all breathing the same air, which is probably going to mean that they will, if they were not, they will be contaminated afterwards. So that's a very good example where a public officer responsible for the healthcare of that small community could, for instance, ask everyone who has a doubt or a situation that they want to check, that they would take one self-test, go home and do themselves, and they would report afterwards or would have access through, let's say, as I said, telemedicine or any other kind of technological support for clarifying doubts. So I do see a need for a wider consideration in this kind of solutions. And unfortunately in Brazil, and that's going to be a topic today, self-test is not yet that much seen as a public healthcare tool. It should be reconsidered. Some cities are considering, most of them are not. The Ministry of Health is still not very certain if it should or not be part of the program. It's part of the program, but they are not going to procure. So that's a point to be considered.
No, excellent. Thank you so much, Carlos. And maybe to reflect on the global, to go to you, Rosanna and Jillian, now with the WHO guidance being out, what do you see as the next step for countries, drawing from what Carlos is saying for Brazil, but also for other regions, when we think of Asia, Africa, Eastern Europe, Central Asia, the Americas more broadly, maybe what your reflections here would be very useful to think about. What priorities do you see?
I like to think that now that WHO has issued the guidance and are trying to engage more manufacturers to have the test pre-qualified or have EU emergency use listing, is that with competition, we could put the prices down, because I think a lot of people would self-test if the price is affordable for them, right? And given that they could be freely available, but maybe not affordable. I always speak about the 3 A's of accuracy, affordability, and accessibility. So here we're increasingly seeing accurate tests we're increasingly seeing accessible tests, but the affordability question is still not resolved. And I think WHO can do a lot to help with that. And you know, from working on the HIV self-testing, that actually WHO's effort in that was just outstanding. So I hope that this can be done again. Over to you, Gillian.
Yeah.
Yeah, and I think what Rosanna mentions is very important. And one point I wanted to make or highlight from the overview that you provided from how other countries have been using self-tests is we really see that self-testing is becoming quite normalized, and it's in many countries it is not stigmatizing. So people are comfortable testing, they're comfortable sharing their health status with their friends and their community members. And I think that's a really unique context here for COVID-19, which is not the case with some of the other disease areas where we've seen self-testing be really impactful. So if we can kind of capitalize on that empowerment aspect and the fact that testing is viewed in a positive light, I think that can really help public health agencies as they're trying to use self-testing as part of their overall arsenal. I think, as Carlos, you pointed out, if we restrict this to only being in the private sector where people can buy these tests if they want, I think it would be a missed opportunity for public health programs. And as you point out, as part of outbreak investigations, as well as to preserve their national systems, because I think right now SARS-CoV-2 has really taken over most healthcare systems. And by using self-testing to complement your existing diagnostic systems, you can now go back to diagnosing all the many other infectious diseases and non-communicable diseases that continue to spread and have even been negatively impacted throughout this pandemic. So I think some of that messaging is really important, and we're hoping then that member states can adopt and adapt these recommendations to suit their individual populations, because it is complex and we need to be cognizant of that. But great question. Thanks, Cheryl.
No, great. And just to push a little bit deeper into this affordability question, I don't know if there's fine colleagues on the line who, Sergio or Elena or Sanjel or others who want to speak about some of the projections around what they're seeing for costs, but that may be useful context. But, maybe a question just for Gillian and Rosanna might be, what are your messages to donors that might be asking about procurement? Global Fund, PEPFAR, have historically procured in the HIV self-testing space. Global Fund in particular has C19RM funding for COVID-19 commodities. Is there a role for donors to play, or do you see this as more of a private sector domestic funding space?
Cheryl, I think it's a mixture. I actually see, many countries are now realizing that they don't want to be reliant on somebody else, right? They want more ability to manufacture themselves. And actually the partnerships that have already started in Africa and in Latin America with companies that are already making these tests, and to make them I guess diversify the manufacturing sites so that you have more low technology transfer and local production in different parts of the world. That would make the accessibility and affordability question can be tackled at the same time. And that I see as a more important way to do it than to just donate tests, right? And we've seen this also for vaccines, even though manufacturing of vaccines is much more complicated than manufacturing of rapid tests. And countries or actually donors have started to support manufacturing of vaccines in different regions of the world, right? So I think that's an important approach that donors and others are taking. Over.
No, thank you so much, Rosanna. I don't know, Gillian, if you want to add, or maybe just seeing if there's anyone from FIND who wanted just to give some context around the current pricing or some of the projections that might be shareable for this workshop.
Sure, I'm here, so I can give a little bit of of insight. So I just want to agree as well with the not underestimating the importance of the local manufacturing. So we do have a lot of Fine traditionally had done a lot of work to secure some pricing, the pricing that manufacturer controls. So that would be the pricing from the factory. And then to that pricing, you have to add the pricing of the shipment and the import taxes. And of course, that actually could add almost as much as the test cost itself, right? So all these prices all these additions are not there if the test is produced in the region. So it makes a lot of sense. But however, we do see a lot of a tendency towards the price decrease. So we see the rapid test became much cheaper compared to where the prices were 1 year ago. So consequently, from the last year, we've made a number of contracts with the manufacturer with the price commitment, so the price from the factory around $1 to $2. So the cheapest one, $1 to both public and private sector. Again, and that's a ceiling price, meaning that if the volume goes high, the procurement agency or the procurer could always negotiate a lower price. So that's the But I guess this is already half of the export price that is existing for HIV self-test. So it's a big step towards the affordability of the self-test. But yeah, so it's reducing all the other components of the pricing would make it even further affordable.
Yeah, and as this is where public and private partnerships are very important going forward, right, Carlos?
Yes, I'd like first to ask everyone who has questions, always use the Q&A or chat so we can view. That's first. And second, I agree, Cheryl, it's a fantastic work that has to be done in order to reduce cost overall in promote access. That can be done via scale. If we do have public health programs around the world considering self-testing as part of their diagnostic mix to be offered, it doesn't have to be one or another. It has to be a combination and use it wisely. This will leverage production and will promote cost reduction. That's very clear. And that's what we want to do. That's one. Second, and then I ask WHO to support us in that, is to review healthcare settings. For instance, Brazil in the past had only labs and hospitals in conditions and legal conditions to deploy diagnostic tests. Exception were public health programs like a family program in the Amazon and so on. All the other situations, you would need the lab to be involved, which is very clear. There is a great benefit. But we learned with COVID that it's important to have new spaces for testing in good conditions, with quality products, so on. And just for example, we are going to have one presentation today about the pharmacy system in Brazil. So we had 6,500 hospitals, 18,000 labs. We added a potential number of 88,000 pharmacies around the country, and they are close to everyone. And like pharmacies, there will be clinics, there will be medical facilities and several others. Even companies can add their efforts if well-trained and capabilities are checked. They also can be part of a pandemic workforce against this kind of problem. So these new spaces must be seen. In Brazil, currently, we are going to review the legislation for this, and it's a possible situation. So I think it's a worldwide effort to see these new spaces on a creative but safely, in a safe way, how we can add this and also promote more scale to the products.
Absolutely. I just want to go to the Q&A because we have two questions that have come in. There's one question from Ana Flavia. Carlos, I might ask you to assist with translation. And then we also have a question from Carmema. asking how long do you consider that the manufacturing of self-tests could be sustained if countries do not implement public policies of testing? So maybe that's just a general question, really reflecting on, the need for the policy to really drive the demand, from that manufacturing side. I don't know, maybe Rosanna, if you want to take that one.
Yes, I think it's very important for companies to know the market size and the demand for them to maintain a production line, right? And if, judging from other epidemics like Ebola and Zika, for example, there's a feast or famine in terms of demand. Normally there's not much demand and all of a sudden huge demand. Manufacturers companies really find it very difficult to maintain a production line or reagents so that they could meet the surge in demand when they need it. So I think it's really important for us to think in terms of policy for a country or group of countries or a region. What would be the demand for the use of self-tests in the days to come, in the months to come, and be able to inform manufacturers? Would we always need some, just like we need some maybe flu tests for healthcare workers in the next flu season, etc.? Those are what countries are starting to think about. How much longer will we need these tests? Or will we now regard, when the pandemic is over, regarded as one of the common colds that we don't bother to test? And so that's a very important aspect of what needs to be done now.
Cheryl, I agree with Rosanna, and that's a key question, especially when we don't know what is going to come next. The next wave, what is going to be, we don't know. We see a surge in Asia, lockdown in Shanghai, Korea going up, European countries also up, and Brazil thinks everything is finished. Brazil and several other countries. So what we have to do? We have to move on, and I will leave the question by Ana Flávia to find. We'll have several presentations later on, and the question is very relevant. She touches on the topic of taxes. Countries like Brazil have very high taxes on different products, including healthcare products. And sometimes we can have a global effort to decrease the impact on products that are essential. And that should be, she's asking what FIND can do, but I also challenge WHO to have this kind of discussion with the state members, at the member states, because it's really something that it doesn't make sense to charge a high tax that is going to be received by the state, who has to spend, if not on the product, on the healthcare later on to be provided to the citizens that couldn't be tested at the right time. So, I would like,
Oh, just to close out, I think, I really appreciate this time to have this discussion, and want to thank Jillian and Rosanna for their really thoughtful comments, for the questions in the Q&A. And I know we'll go into it the rest of the workshop, but maybe a good reflection here is, after working on self-testing for about a decade, these questions are very similar to me, whether it's HIV, hepatitis, STI, syphilis is where we're working to develop guidance even now at WHO. These are issues that I think are cross-cutting. And it is really important, as maybe we go through the workshop, to think about, how we push towards a broader self-care, self-testing strategy for countries. Brazil is quite a leader in HIV self-testing, and many other countries are leading on a variety of self-care and self-testing packages, and COVID might be just one of those. So very important to take that forward, and I'm excited to learn from the rest of the speakers. And thank you so much, Carlos, for assembling the group, and looking forward to the rest of the workshop.
Fantastic. Cheryl, Jillian, Rosanna, thanks a lot for your fantastic contribution, and the work is always open for you. Whenever you want to bring anything new, we are more than happy to have new sessions as well. Gostaria agora de convidar Dr. Cláudio Mairovic.
I would like to invite Dr. Cláudio Mairovic, that he's going to be the moderator for the next test session, self-test as a public health tool. He's a sanitation doctor. He's working in Fiocruz, but he was the director, he's a president, and he worked in the Ministry of Health in one of the boards, if I'm not mistaken, SVS. So Claudio, please welcome. The floor is yours. Thank you very much. Good afternoon. Thank you for the kind presentation, Carlos. At first, I would like to congratulate the audience, congratulate Carlos on his effort of more than decades that he's successfully bringing the diagnosis area to the core of discussions, and he was able to bring to another level in the scientific discussion, the technological discussion, and also the access of healthcare in Brazil. I will congratulate Leticia also in being successful in implementing Alavive. I would like to mention Aladiv partner, CBDL, Professor Rosana, present in the event. It's a satisfaction to participate in this first table. It was quite stimulating. So I will allow myself to make some brief comments around our topic. That's the self-tests as a tool for public health. COVID that we lived as a tragedy in the entire world, particularly in Brazil, is the biggest humanitarian tragedy recognized in our history, without considering other tragedies that we had before the past. But we live COVID as a crisis that started and came upon us when some changes we had we changed some paradigms, not only in Brazil. This was happening. It was happening in a lot of places, especially nations with high income, but some that we had as possible revolutions in the health area. I will mention here the incorporation of tools that embed artificial intelligence in diagnosis area, in treatment area, epidemiology, also telemedicine, that in our country was seen in a careful way with a lot of taboos involved, because between the pillars of our medical organization, the traditional one, it was always the direct contact between physician and patient and the professional health service. It changed completely during the pandemic. I think that we are learning a lot with that. And in the diagnosis area, the fast tests, point of care that we call, it were being used as technologies in our health system in a lower speed than the innovation capacity that they represented. Once that talking about fast tests that's done, the point of care tests, it's a reorganization of the diagnosis area that's not related to not only to the kits, to the materials used for the tests themselves, but a reorganization of the services, of the flow of people, users, professionals, and also the information flow in the system. Also, in the diagnosis area, in the Brazilian case, an action that maybe wouldn't be enough compared to the auto tests that we had from Brazil. It was the self-tests for pregnancy only. The other tests to measure glycosis with stripes and devices that people keep at home. And we were following the recent the recent use. I think that we're going to have a discussion about this, about the self-test for HIV in Brazil. And with that, We had technological modifications with high potential as the multiplex tests, the same test being able to diagnose, to have the diagnosis of different diseases using PCR technique or point of care. So these things are the background of what we live nowadays as an innovation potential. We went to the self-test discussion of COVID in Brazil in the end of last year. So we had a lot of discussions about that, but we should remember that some of the attributes of this as an advantage for these self-tests that we had in the discussions. Attributes as being ease, faster, the privacy, the possibility of reducing the cost of the system, biosafety, as the person doesn't need to go to a place to do the test. It was mentioned before by Hosanna. And the autonomy and the possibility that people can have on their reach a device that allow them to have the diagnosis and doesn't depend on third parties. These are innovative things.
And now we see that there are many possibilities for future perspectives. And we should always remember that in our point of view, and this is the topic of this discussion, it's not only looking at technologies, but also how appropriate and how much it's possible to have new technologies as public policies. And for that, we have a lot of different paths related to the technological matter itself. We have aspects that are not only regulatory, but they are aspects related to quality and trust from professionals and test users that may demand some type of process that today is not enough on the controls that are done for the registration. So it's a moment to consider possibilities and certifications, or as auto tests are assisted technologies, the self-tests are based on technologies and what we can achieve through accreditation as well. Just to remind you, we will have many tasks for different factors. We have what we already mentioned in terms of the costs, like we talked about before. It was very frustrating for professionals that need to defend COVID self-test to see that the self-tests came to Brazilian retail with prices very similar to the tests that were done in the pharmacy, the antigen rapid tests. So this means there's a big variety of topics that need to be approached, that need to be handled so we can evolve. So now I'm going to use the terminology that Carlos Morello used, ex-president of Fiocruz, when we see that we already have enough knowledge for this. So it's not a science failure, but there are market failures to see that these products have high prices, low competitiveness, and maybe not and it still exists in the service market, and there isn't a public policy for the offer of the tests. So these are topics for us to approach through this time. And for that, other than topics that are considered related to the interest of anyone who wants to present, I'm going to ask Mariana Vilares to come forth. She's a master's in engineering for innovation, and she leads the team responsible for in vitro diagnosis on the, I always confuse this, chronic infection conditions for the Ministry of Health. So she's responsible for in vitro diagnosis, and she has been working with important innovations, among those, the one I mentioned. And now I invite I invite her to tell us about the experience with Brazilian self-test. Hello, everyone. My name is Mariana. Thank you for your presentation. It's very nice to be here. I'm very grateful to be here to tell you a little bit and show the experience we've had in Brazil with the HIV self-test for our public health system, how we implemented this with public policies in Brazil. To give you some context, I don't know if everyone who's on this event understands a lot about HIV, but just to give you context, we have the 3 cascade bars for HIV in Brazil. And the first bar, which is the diagnosed bar on the left-hand side, we can see that in 2012, we had 69% of people living with diagnosed HIV in Brazil. And in 2020, we had 88% of people with HIV diagnosed. This is completely related to the rapid test implementation of HIV on the primary care facilities. We talked about this in 2012 and we expanded a lot. And we take the test up to the user from 2012 to 2020. That was a main difference. Anyway, the closer we are to 100%, the closer for us to reach our goal, the harder it is for us to be able to increase the percentage. So it's a huge challenge. How can we increase diagnosis? Because we reached 88% of diagnosed people. How do we reach 100%? How do we find these people? And knowing that in Brazil, we have a concentrated epidemic, the prevalence of the general population is 0.4%. And in other populations, for example, gays and other, we have 18.4%. Sex workers, women who are sex workers, 5.3%, and trans women, 17% pretty much. We have a concentrated epidemic, and to be able to get out from 88% and get to 99, 100%, we need to focus on this population. And at the same time that this population is the population that is not being reached, that is the most vulnerable population that have a hard time accessing primary care. So for that, we need a strategy that has focus and accessibility to make sure every population has diagnosis. With that, since 2018, Brazil implemented the HIV auto self-test with another strategy to implement this diagnosis in the Brazilian public health system. How does the distribution of self-tests work for HIV in Brazil? We have a goal of reaching people who are not diagnosed, which are the ones that are facing some challenges. So the focus is keep and prioritize population that are not reached by our regular public health system. And what are the main strategies that we use to reach this population? The distribution of self-test outside health services, and also the secondary distribution, which is between pairs and partnerships to make the test reach the population that it currently doesn't. So we have 3 main strategies for distribution of self-tests for HIV in Brazil. The first one is for PrEP users, for them to deliver this to pairs and sexual partners. We know that PrEP users are people who are vulnerable, that probably are among others who they know who are still in the same situation. So it's a great strategy to make the PrEP people help us reach other people who need to be tested, but they don't use these health services. Another strategy that we have is distribution in social location for key population and priority populations that can be done by health professionals or civil society organizations. So these are distributions outside the health services where the populations are. So parties, bars, social places to be able to reach this population. Lastly, people who go to health services so that they can deliver them to friends and sexual partners. The auto test, the self test is not going to substitute the technology, the professional technology, like we said for COVID, but it's another tool to be able to broaden the possibility. So for health services, they're going to have the test on the health location or the primary care unit, but they can take the self-test to friends and sexual partners. And the Brazilian strategy contemplates that each of these people can take one self-test for themselves and up to 5 self-tests for other people. These guidance are inside this document that is on the right-hand side of the slide, which is on our website as well. So all of those strategies that we use in the Brazilian public health system are in this document. I'm creating a parallel with what was mentioned before as well about information and communication. So when we're talking about self-test, which is a tool that the user is not a health professional and they're going to do this at home or somewhere else, it's important that they have full information and clear information. So when should they take the test? Where can they take the test? And depending on the result of the test, what are they going to do? What are the next steps? And it's also very important to have support if it's over the phone or other channels so that the user can ask any questions if it's necessary. So we have a specific website about the HIV self-test. And inside this website, there's a lot of sessions, different sections with information so that the users have all the necessary information for the test. So we have pamphlets to be delivered with the test, posters that can be pasted where they offer self-tests. We have videos showing how to perform the self-test. We also have a video saying what the self-test is. We have a man and a woman, and they have the characteristics of the general population and the key population as well. The characters in the video, they talk a little bit about health. So it's like 1 minute video. We also have an interactive panel as part of this strategy in Brazil. And we also have a FAQ section so that the user can go in there and see questions that are commonly asked. About monitoring. Monitoring is going to help us make decisions to adjust the strategy and also update public policies whenever we think is necessary. This has been very important throughout our process ever since 2018. Everything that we find in our strategies, we are able to adjust to make that strategy better. So for monitoring, we have the 2 main tools: filling out an anonymous form with information about sexuality and location. It's a very short form. I think it's 6 or 7 questions. There are multiple choice. And the most important thing is that it's anonymous, because this cannot be an imperative for the person to grab a self-test. It has to be simple and quick. And we also have another way of recording this information, which is for people who are already patients in public health system, or people who live with HIV or in PrEP, who can bring these to partners, the consultation applications that we have. And I brought some result data from this policy to show how important this is for us. We started in December 2018 with a pilot in 14 municipalities. And in January of 2020, we were able to open it to Brazil as a whole. With the success that we had and with the population that we reached, which was the goal population, we were able to open it to Brazil as a whole in 2020. Then we had the pandemic. In April 2020, we have the recommendation about social distancing. So we saw a little bit of a break in the distribution, but we had a few webinars and we had a lot of incentive towards using self-tests because of the recommendation of social distancing. So this was a way of maintaining the testing offer for the test population and for priority population during this recommendation of social distancing. And a lot of people were afraid of the health system, so we stressed this, and it brought a great growth until September to October, November. We had high levels of distribution of the self-test in Brazil, and this growth ended the stock for our self-tests. We purchased again in April 2021. We had the new purchase, we received the new test, and we can say that it went up drastically as well. So far, we have the distribution of 419,795 self-tests on the different strategies that we have in Brazil. Here, I'm showing the amount of municipalities that are a part of the strategy. So there's also a growth and reduction, then growth again. So in November, 124 municipalities distributed it in Brazil, and accumulated the municipalities who have distributed at least one, so it's 256. And we want to keep increasing that over the next couple of months. And here I have some distribution data, some results from our distribution. So in average, we have 3 self-tests registered per person. Like I said, each person could grab 1 self-test for themselves and up to 5 for friends and partners. So we have an average of 3 self-tests that were gotten from people who have HIV and want to bring this to partners, and people who are in PrEP who want to bring it to partners as well. And for the distribution outside these services, the average is a little bit smaller. It's 3.2. So people who are approached in the street or the sociability actions, we have a smaller average. Maybe because these people are very used to having self-tests, maybe they aren't as shy as to getting the self-test.
About the age of people that receive the self-test, it's an important information. 20% of the people that receive the self-test, that not necessarily these people took the self-test. We're talking about the distribution. 20% of them was between 18 and 24 years old. That's a young population. And that we know the young population, especially in Brazil, they're suffering a lot with new diagnosis. And 22% of the population that received the self-test was 25, 29 years old. So 42% of the self-test was distributed for people in between 18 and 29 years old. On the right side, we have a chart that's quite important. That's a data from the form. That's when was the last test for HIV that the person did. And 20% that got the self-test never have done this before. It was the first time that they did this, what shows that we have a strategy focused on getting into this population. We have 13% of people that tested more than 2 years, that we know that the population needs to be tested with a higher frequency. And an important data, as I'm talking about young people, that people that have never done the test, when we go to the people between 18 and 24, 20% have never tested before for HIV. So we believe that this distribution of the test is being able to reach these young people. About the gender identity, the majority of them, if I'm not mistaken, 52% of the population are gay people. And I get your attention to the trans population. We have only 5% of this distributed to the trans population. We're trying to have an effort to reach this population. That's a population that needs this technology. People that have some issues about going to the health system. So this is a little bit higher, but we'd like to increase even more this percentage. About race and color, we are divided. 50% said that they were white or yellow, 49% Black people, and 1,000 indigenous people. And this is just a slide to show that this data that I showed, they are the interactive panel. We have the address here, where I'm going to share this presentation. If you want, you can filter this by state. For each type of strategy, in each unit, in each state, everything's available in our website if you want to check the strategy in Brazil. and this other one, and bringing something new that I didn't present the other times. We are applying a questionnaire after the test. These are distribution data. The people that received the test, not necessarily were the people that took the test. So since the beginning of the strategy, we had the post-test questionnaire. So for those who took the test, you go there, it's anonymous, and the person could answer some questions to us so we know how people are accepting this test. How is the population that's using the test? This in our website too. And if you pay attention to it, in the label of the self-test distributed, in the end of that, there's a QR code that goes to this questionnaire, so it's easier to the user after doing the test to report to us this information. And also in a brochure that we delivers with the self-test, there is the QR code so people can go there and answer this. But it is a voluntary answer and is not something mandatory, so we don't receive so many answers from the distributed tests. But we have interesting data of this post-test questionnaire. If it's from January 2021, we had 813 answers. I think that we have 1,300 right now. 45% of them that answered this were gay men. 50% was between 18 and 29 years old. 45% reported having anal sex without protection in the last 6 months. 32% were taking the self-test for the first time, and 32% have never done this test. If we go to that range of 18 to 24, so they have never done a test like this before. About accepting this, 91% of people thought that it was easy, 98% said that would take the test again, and 99% would recommend the test to a friend. These two charts are interesting. It shows to whom the person took the test, how they were able to get the test. So to summarize, the person who took the test, 80% of the people, even though there's the possibility to have support from a health professional, 80% of the people didn't use the support. A lot of people, it got our attention. A third of them have done with a friend, a partner, or someone from the family. So in Brazil, they are taking the test with other people. And how they got the test, they can buy this in the drugstore. It was available. They can get the health service, can receive from an NGO, or get from a friend. It shows that if 53% of the people that answered this questionnaire got the self-test outside the health service. So it shows that we're able to reach people that not necessarily are going there to these services. The last one, two important results from the people that answered. We have 34% of people said that they had a radiant result. In Brazil, 0.4%. This is wrong, this data. And from these people, 79%, they already tried a health service to have complementary tests that sometimes are afraid when they do the self-test, they don't go to the service. So they answer to the questionnaire. 79% have gone to a health sector to get this to get health help. So they had the questionnaire as the main advantages of the self-test. First, the privacy. 72% said that this was an advantage. And personal empowerment. 51% said this is also an advantage. I think that was what I wanted to present. I think I'm over the time. So thank you for the opportunity to present this strategy to you. And I'm available to answer questions. Thank you very much, Mariana. Quite interesting, your presentation. I think that, again, it shows how important is this public health. Since we started this AIDS program, that we have other things now, we have hepatitis, we have other diseases, and now working with tuberculosis and other disease that helps to get new models with the public health area. So congratulations for your presentation. Now I invite right now Dr. Patricia Garcia, that's a sanitation doctor, was the Minister of Health from Peru and a researcher in that country too. So please, the floor is yours, Dr. Patricia.
Muchísimas gracias. Voy a compartir mi pantalla. A ver,
Thank you very much. I will share my screen.
¿se puede ver?
Can you
Listo.
see my presentation?
Voy a comenzar agradeciendo a Carlos y a
I'll start
todo el
thanking
organizado
Carlos
toda esta presentación.
and everyone that organized
Quiero ver cómo
this
apago
activity.
el translation acá. ¿Cómo lo hago?
Now she's trying to turn off the translation for
Yeah.
her.
Interpretation off. Okay. Ahora sí. Muchísimas gracias
I was
por
able
la
to do
invitación.
it. So thank you very much for inviting me, and congratulations. Congratulations, Carlos, for your leadership in these topics that are related to diagnosis test. I will speak in Spanish because we are in talking to Latin America, and I know that a lot of people that speak Portuguese can understand Spanish, and we also have simultaneous translation. The topic today is self-test as a tool of public health in a globalized world. So let's start talking that of the point of view of the language. I mean using self-test. I know that in Portuguese you use the same, but we need to be sure that this is the right word to use. So I use this word in Spanish, but I think that we need to maybe to have a specific word in Spanish. I don't know how people would understand this. When I was talking about this in Spanish, is related to car. Are you testing a car? So this is something new. So we need to make sure that people understand well. And if people understand, they can know what's going on. So the health in this century is changing. So we have the demographic change, we have pandemics, we have climate change, humanitarian crisis, mental health problems that represent an increased load of diseases in the interconnected world, social pressure, and technological pressure. Things are changing in the world in this century and also for the health. As someone brilliant said, we cannot intend to do different things if we don't change what we do. And the challenge in this century is how to adapt the health system in public health to promote the prevention and to make sure that we have the access to health care so we have resilient service. With the health concept that we have for the community and for that, we would need to have a technological development and innovation. And this innovation needs to be accessible and the right one for the different needs, the different means in reality. And that can be environmental friendly, that needs to be close to the community. And one of these concepts is a new concept because we need new things for this world that's changing so much. The concept of an intervention of self-care, that's also a translation that we have from English. So it's called self-care intervention in English. So the WHO has a guide for self-care. So these guidelines are about drugs, diagnosis, products, and technologies based in evidences that can be totally or partially separate from the health services that can be used without the support from a health worker. And on the right side, you can see in all these interventions of self-care, the self-testing is an important part of that. And the self-tests are the ones that can be diagnosis tests that allow to have your own screening, your self-diagnosis, or even the self-monitoring. So the WHO gave this guideline in this context that we need to empower people in a number of aspects, and one of this is related to self-testing. In Lancet Commission for Diagnosis and Testing, in the report published in October 2021 about how to transform the diagnosis tests, we had 7 key messages. The first one, almost 50% of the world population has low or no access to diagnosis tests. And this is related to the fact that is not financed because they are related to levels that people are not able to achieve. That's why I would like to go to the primary care, because this is fundamental to improve equity, and also that innovation that are new can help us to transform this access and can be more democratized. An example of that, of the self-test, to work this transformation, we could avoid at least 1.1 million of deaths per year with a better access to diagnosed tests, thinking about only key diseases.
Each dollar goes to many dollars in benefits, and it's interesting to understand why it's important and why we're going to use it in an effort for public health. The innovations, recent innovation can make the process more democratic because the tests can somehow be digitalized in the attention point. And we already have examples of tests that are so simple, so stable, and maybe so easy that they can be used as self-test. The experience in Brazil with the HIV is very interesting. And in some of our countries, we tried this experience, but so far there is a series of barriers and this wasn't able to be implemented on a national level. But the innovation is out there. And I believe that in the context, it's important to talk about how we can convert these tests into tools for public health. Now, the citizens are interested in diagnostic tests and self-tests as well. We have studies in Peru for very long ago of using self-tests and shows that most people would like to use the self-test instead of regular tests. And they would just ask for us to have clear instructions and somehow a guidance of what do you do with the result, which means reference. We did these studies in general population in different places, and we were going specifically towards asking about tests related to pregnant women, sick children. However, it was too broad. The need that we found was too broad from the citizens to have access because they believe in the technology. What they told us is that they would prefer the type of sample as well. So, for example, saliva instead of blood. But however, when it was a prick in the finger, that was also acceptable to people. Other than that, women and men are willing to pay for self-tests that are sold freely. And even though we have health insurance in the country, which is or a public health system, what we understand is that the system many times don't have everything. Some things are lacking. So we say if it's not as expensive, we can pay for it ourselves. And that can create inequality as well, because the ones that can pay will, and the ones that can't won't have the test. However, the citizens are interested in that. They are not afraid of it. And to see how self-tests can really approach critical challenges in public health, I wanted to bring an example, which is one that we are working with, which has to do with the cancer in the uterus cancer. And women die in Peru every 5 hours because of this uterus cancer. And this is because of the cervical cancer makes them afraid to go to have a pap smear. And most women are diagnosed only in very advanced stages, even though they did a lot of pap smear tests. Now we know that the HPV that causes this cervical cancer, we have a lot of things to capture HPV and to catch the problem before we reach cervical cancer. So we have molecular tests that are easy to do with accessible cost, and they can be done by women at home. Another way of self-test, which is the self-sample. So the woman will get her own sample. This is quick and easy and makes them more, they have more self-esteem, they save time, they have privacy and autonomy. And women in a capacitated community can talk to other women, and this can be very powerful to share this knowledge, self-test and self-care. This is what we have been working with. And we have been working with the HOPE model. And what we want to do is we want to create this model where people talk to other women. You get the self-test, you take it at home, and these samples can be deposited in collection places. The samples are gathered once a week in bikes. They are processed, and if they are possible, if they have a positive result, we would reduce the number of women who really needed to go to the healthcare center to have treatment corresponding to that. And then we would focus our attention on those women. Based on that, we have changed regulation, national regulation. However, there is still a little bit of resistance on the professional side, letting women take the test at home and getting the sample at home. In some places, as we said, they said, no, it's better if we monitor them. However, we already have in the country some models where this is being done and it's advancing, and women are empowered by that, and they are taking their own samples and their own tests. And this showed us that it increases our coverage. This is an example that we are still working on the implementation, and we went to implementation on a nationwide level. However, it hasn't been easy, as I've been telling you. However, the pandemic is giving us new opportunities. As Rosanna said, all over the world, the tests were, however, the test centers and health centers are overloaded with people. And when we have these antigen tests that were available, they were quick for one, and two, they gave us the opportunity for self-test. But due to existing regulation in many countries, and one of these countries is my country, Peru, in many countries, we couldn't introduce this fact of having self-diagnosis or self-test, or being able to have the tests available for people so that they could do it themselves. However, and even though Peru started very early and they were using the rapid tests, it was always tests that were done by health professionals. So we suffered a lot with this overload in our health establishments and our test centers. But the concepts, and this is because we are in a globalized world, the self-test concept came to the country through social media and through a lot of factors. And people, the public, actually started to ask, why in other countries they have self-test and it's not allowed here? And this created a demand. And our office, which is the regulator of medication and medical devices, including diagnostic testing in Peru, finally recently has approved the availability of self-tests for COVID in pharmacies. For that, we had to review and recreate some regulations, but they were only temporary and specific for the self-test. However, this increased autonomy, reduced risk, saved time because people could just go to the pharmacy. At the beginning, this also conditioned some issues because number one, the tests were really expensive and there was no control for prices. Whoever could pay for them did, and they had a lot of tests at home, and that was it. There was no control, quality control of the tests that were sold. And more than that, there was a parallel market of selling tests online, which were not very well managed. And a lot of us working in public health, working with written and television media, we started approaching the topic that the tests that were sold online didn't have any control, and we needed to pay attention to that. Another problem that came up was segment and result notification. But in the middle of the third wave that we had, being able to have tests or self-tests has allowed somehow to reduce the pressure that was there, the problems that we had because people were demanding to have tests, they needed to have tests, and no one, not the private centers, not the health ministry centers, were enough. But this has shown us, I don't know how we're going to go as a country, but I'm talking at a LATAM level. There's a lot of critical points about the self-tests. We need to make sure that they are adapted to users, that they are validated, and they can make sure of its quality. And also knowing what are the mechanisms or the distribution and sale channels that can have some type of formalization and that can have monitoring. We need to see what link we can have with the formal health system to be able to derive from and also have information. And for that, a question is how to cancel connectivity. The connected diagnostic tests could be very useful for epidemiology, for investigation, and for patients. I know it's a challenge. In the case of COVID, the recommendation from Dr. Rosanna Peeling that it's better to continue the virus presence as well, or residual in residual water. It's also something that we need to understand, that people need to be connected and understand what is the positive test, and that needs to be connected inside the health system in case of COVID, for example. And over the last years, we understood that there are barriers that we need to work with inside our health systems. The acceptance of results on the formal health system. Many times people would go with their own test and the system would say, no, we don't believe this. And they would have them do another test, but there were no other tests available. And it was really hard to get close to that. So at the end, you would lose the window of opportunity. There are economic interests as well, because the self-test has actually competes with labs that provide paid services for tests. And they may have, and they have had important lobbies about the regulations that have not allowed for people to sell self-tests for HIV in the past, for example. Now there are the changes in power dynamics, and they feel like that's what's happening, and how people are going to have control and health professionals are going to have control over something that before it was only limited to health professionals. So it's something we need to work on together. However, we can't not recognize that definitely as a tool of public health, it can increase coverage, it can reduce differences if we can make sure that they are available and they have similar prices, and that it can be distributed through communitary agents. You know, that they are highly accepted by members of the community. They can empower members of the community, and they can also reduce the overload of health centers, leaving more time for those people who need more attention. So I would like to leave you. These are community agents in the Amazon, and they have also been working on another project talking to other women about tests and self-tests, and they take the tests and they train other people. So the future of health is in the hands of the people, and I believe that this is the time to empower and make the test more democratic through self-testing, and this is not going to damage health professionals or public health. Actually, on the contrary, it's going to strengthen public health involving the community. Thank you so much for your attention. And I will now go over to the next presenter. Thank you. Thank you, Professor Patricia Garcia. It was a very interesting presentation because it brings us this point of how these new technologies can have this in our favor, and not only technologies that are available for curiosity or individual use. So I think that's one of the main questions that we need to answer. Our third presenter, Elliot Cohen, he's a specialist of regulation in partner diagnosis, and he worked for FDA in vitro diagnosis. Unfortunately, couldn't be here with us today. He couldn't be connected at this moment, so he gave us a video that will be shown with his presentation. Thank you.
Many thanks to the organizers for the opportunity to be part of this important webinar, and my apologies for a scheduling conflict that didn't allow me to participate, so to speak, and to answer any questions you might have. Nonetheless, I hope I can provide you with some useful information on how the US FDA has and is handling self-tests, focusing on self-tests for SARS-CoV-2. The actions they've taken could very well open the door to self-tests for other conditions.
Bruno, se você
Let's
puder
start with
colocar
some
no modo
definitions.
apresentação, por favor.
This has been more of a challenge than you might think, as
Só um instante, por favor, e nós vamos colocar no modo apresentação.
Just a minute, we are going to put in the presentation mode.
as there isn't a perfect one. This can include terms such as self-tests, at-home tests, and over-the-counter tests, all referring to the same type of device. So these tests these are tests that can be purchased and used by anyone at home. They don't require a doctor's prescription. If manufacturers intend to sell their test kits over the counter, they have to demonstrate that untrained laypersons can perform the tests and get good results. Again, note that no prescription is needed, giving individuals the opportunity to test themselves. Because of this, test performance needs to be evaluated in the hands of intended users in an intended use setting. On to a brief history of infectious disease over-the-counter tests in the US. I say brief because there really isn't a lot to discuss here. There are actually a number of cleared OTC tests for non-communicable diseases. Tests, for example, for cholesterol, menopause, ovulation, pregnancy, and prothrombin. However, when it comes to infectious disease over-the-counter tests, there remains only one. The HIV OTC test from OraSure that was approved in 2012. It wasn't until 4 years later that FDA convened a meeting to discuss risks and benefits of OTC tests for flu, for CT&G, and for strep A. For those interested, I included a link to the meeting materials, but in short, there was a recommendation for CT&G tests as a priority, followed by strep, along with a concern about self-collection of an oropharyngeal sample, followed by flu. There really was no activity in this area until 5 years later when the first OTC test for SARS-CoV-2 was given an emergency use authorization, or an EUA. Even then, that test wasn't authorized until about 1.5 years after the public health emergency was declared. FDA had actually identified what it expected to see in an EUA in July of 2020 when it published its template for manufacturers of molecular and antigen diagnostic COVID-19 tests for non-laboratory use. Non-lab use was FDA's term at that time for an OTC test or a self-test. This was followed by 2 revisions to clarify FDA's thinking on what information is needed to support an authorization. Also, FDA revised its policy guidance for COVID-19 tests in 2021. This policy guidance made clear FDA's priorities for COVID tests with a focus on increasing access, and it's important to note that this included the need for. Now, the templates play a very important role in the regulatory process for emergency use authorizations. They provide specific instructions on what FDA needs to see. They identify the exact wording it needs to see for such elements as the intended use and details on studies that are needed, including those for analytical studies. These would include limit of detection of variants, which is an ongoing activity, of course, and cross-reactivity, as well as information on clinical performance studies to establish claims for positive and negative % agreement, similar to respectively sensitivity and specificity, but reflecting that there is actually no gold standard test for SARS-CoV-2. There's also a section on manufacturing capacity, so FDA can prioritize tests that can meet demand. Currently, that's set at 500,000 tests per week, or 2 million tests. This slide shows you yet another timeline, in this case showing when and how many tests were authorized relative to other events. I want to call your attention to the right-hand section of the timeline, which shows the number of authorized OTC COVID tests in each month. As I mentioned before, the first OTC test was authorized in October of 2021, with gradually increasing numbers over the next several months. This was preceded by publication of the revised OTC templates and revised policy guidance that prioritized authorization of OTC tests. As of now, or at least the last time that I checked, there are 15 authorized OTC antigen tests. I also want to mention that there are 3 authorized OTC molecular tests, though they are significantly more expensive than the antigen tests. Speaking of cost, antigen tests were being sold for about $25 to $35 US, meaning that many people who wanted to test themselves could not. In response, federal, state, and local jurisdictions made large purchases of OTC tests, again with the goal of increasing access, and those tests are being provided to the public at no charge. It's important to keep in mind that there are some issues with OTC testing. This includes challenges to reporting and tracking for public health agencies. Many of the tests don't have the ability to communicate test results to these authorities. Likewise, it's difficult to monitor test performance to determine if tests are actually meeting their claimed performance levels. However, there have been several recalls of tests that have had issues with false positive test results, and FDA is quick to act on those. Most antigen tests are packaged for serial testing, which people may not realize, with 2 tests per package. The intention is for someone to test once and, if negative, test again 24 to 48 hours later, especially if they have symptoms. It's likely that many users are not following this procedure and simply taking a single test. There have also been some issues with fraudulent tests and tests that are being marketed without an EUA, and again, FDA is quick to remove those tests from the market, or at least as quickly as it can. So, where to from here? Given FDA's experience with COVID self-testing, I think it's likely that FDA is going to be more open to OTC tests for other infectious agents. FDA is encouraging manufacturers of OTC COVID tests to receive a full marketing authorization rather than just an EUA, and this approach could set the stage for more open thinking on OTC tests for other infectious agents. There's also a greater public acceptance for self-testing with a greater sense of control over individuals' healthcare decisions. And finally, there's also the opportunity for telemedicine to play a very important role here, not only for cost and efficiency, but from a public health standpoint as well. So infected patients will very efficiently transmit their infections in public. So isolating from others can play a big role in preventing the spread of infection. I hope this provided you with some useful information. If you have any questions, here is my email. Please feel free to write. And again, my apologies for not being with you live for this discussion. Thank you very much again, and obrigado.
Agradeço aqui a distância
So I'd like to thank the collaboration. It's interesting to see a country with different paradigms, different point of view, not only in regulation, but also in the professional practice. That's it's easier to assimilate procedures that are there for people. Carlos sent a message to us through chat that we have run out of time to have a discussion. So ask for all of you that have questions. You could add these questions in the chat or in the Q&A that they will be answered in the end. So now, Carlos, Eduardo, I will thank you. And I thank everyone that presented and everyone that are participating here from this session. Thank you, Claudio. I thank you in a special way for your attention and for your work that you've been doing the public health system, and it's a good example, and you are my inspiration for a lot of things. So I'd like to invite now the next table, self-test in the theory to practice. Moderator will be Pamela Gaspar. She's a pharmaceutical biochemistry and has a doctorate in public health. She's working for some years in the development of public health regulations and also the implementation of self-test in Brazil. She's in the General Coordination in Infection Department. So Pamela, please, you can start. Thank you. We can hear you, Pamela.
Estão me ouvindo agora?
Can you hear me now? Yes. Okay, thank you. Sorry. So hello again. Good afternoon, everyone. So first of all, I'd like to thank you for inviting me and the participation of all of you in this important event that's discussing the self-test to broaden the access to diagnosis and self-care. So to our first presentation, I'd like to invite Dr. Marcos Paulo Barbosa Jucá. He's a pharmacist, microbiologist, and a master in material engineering. He works in vitro management and the National Department of Healthcare. So you're welcome. Thank you. Good afternoon, everyone. It's a pleasure to be here with you in this webinar. Just let me be sure that you can see my presentation. We can't see yet. Now you can. It's in presentation mode, right? Yes. So it's a pleasure to be here with you. Today I will have an approach from the regulation side, from Anvisa side. So the risk of the products and the self-test in Brazil. So I'll talk about the history and the current situation. Aligned with the previous presentation from our friend from FDA that checked the risk and the benefits of the new technologies. Just a second, I was not able to go to the next slide. So I will use RDC 36 from 2015. That's what the legislation that we use now, it's being revealed, but this is what we use. So the self-tests are possible to be used in Brazil since before this. But the guideline that we have for the general record for in vitro diagnosis is the same one for the self-test. So I use the definition for the self-test in Brazil. It's a product for the follow-up of the conditions of a disease or to detect specific condition, with the idea of helping the patient, but it's not useful for diagnosis, can be done for any person or health professional or by a lab. Just to highlight here that we cannot use for diagnosis, is not a conclusive information for diagnosis. So a self-test needs to be confirmed with a professional test for a final diagnosis. So according to the RDC 36, the current rule, all the products for self-test in Brazil needs to fulfill some requirements. Some of requirements are common to other professional products, and some are specific for self-test. In the common requirements, we have the development, the performance of the product, specificity, sensitivity, cutoff, Poisson effect, accuracy, precision, interference, and stability studies that are important in a country that is so big as Brazil. We have in the state, we have different moisture, different temperature in different states in the country. So we have this use, the transportation and storage, and also to validate the procedure and cleaning if we have some equipment being used for the tests. Besides these common requirements that are the same for other tests and also self-tests, some are specific for self-tests. So we have the usability study and risk management. This is the main difference for regulation of a product that maybe can be similar or identical to a professional test. But the manufacturer needs to pay attention for the usability of the product. We need to be sure that any user from different age range with different socioeconomic condition and also knowledge can do the test and get the same result as a professional person.
So the usability study and risk management towards risk related to a layman user, the environment outside clinical labs, the environmental conditions for this use, they are very important tools so that Anvisa can evaluate if the risk management is able to reach the risks related to its use by a layman user. But we are still in 2015, so RDC 36 still has some issues. Not all products can be registered as self-tests in Brazil. The most common ones are glucose, ovulation, cholesterol, HCG, HIV. So this is something that is already commonly used in Brazil. And why is it not open for everyone? RDC 36 has some specific areas. So blood type, identification of drugs and metabolics cannot be self-tests, just like genetic testing, tests for compulsory notification, which can identify communicable diseases, which is the case of COVID, also cardiac or tumoral markers, and they're not used for diagnosis. The HIV self-tests, they are allowed in Brazil because still in 2015 with RDC 52 in 2015, there was already a policy that was related to self-tests, like my colleague from the health ministry has already presented, and it's a specific standard which considers the regulation of self-test products for HIV. Until the beginning of 2022, this didn't exist for COVID-19. So there was a change in the scenario. We reached 2022, and at the beginning of the year, the health ministry, through the National Plan of Expansion of Tests for COVID-19, PNE test, got the self-test introduced for COVID-19, specific for COVID-19, because until then, the self-test tool hadn't been presented on the national test for test expansion, on the national policy for testing in Brazil. From there, in January 28th, 2022, Anvisa was able to publish the RDC 595, which is a resolution, and that opened the possibility of having self-test for COVID in Brazil. Now, with the self-test available in Brazil, the definition that was given by RDC 595, I'm going to read for you. Medical device for in vitro diagnosis destined for the use of a layman user on themselves, based exclusively on the instruction supplied by the manufacturer. That's what RDC 595 from 2022 brings. So now we have two current RDCs, 36 in 2015, which is general for self-testing, and RDC 595 for 2022, which specifically talks about self-test for COVID-19. So thinking of how easy it is to use and the risk-benefit ratio, some measures were adopted for 595 2022. So the target is always antigen. Sample is always a nasal swab or saliva. You can see that it's not, it's always a nose swab, which is easier to collect. It's more simple, and it's also quicker to sample, and it's not as hard for a layman user. Methodology is always immunochromatography, which is qualitative. So one step, you don't need sample processing, and you can reduce the error rate. Minimum performance for sensibility and specificity, respectively. Sensibility 80%, specificity 97%. And I should highlight that 100% of the tests are verified before authorization. This is a previous analysis done on INCQRS. It's an official Anvisa lab that tests 100% of the products before the authorization of sale that they have. As we said, the goal is triage. It's mainly for guidance. And there are some requirements for use, which is when to use the product, what are some preventive measures for the for getting COVID-19, which is specific for Brazil, pictures that are going to show the user to understand how to do the test, what do you do in terms of when you get the result, and the access to a number to call and report results. I'm going to show a little bit about the scenario for distributions of the products, about the effort that Anvisa had to make this available as soon as possible, and bringing products that have the minimum requirements that were established. The entire technical team for management of in vitro diagnosis has been focusing on the analysis of the processes related to facing the COVID-19 pandemic. Ever since the beginning of the pandemic, we already had over 1,000 evaluation processes submitted. For self-test processes, we had 105 products. The first regularized for self-test was February 17th, 2022. So the first standard was for January 28th, and then February 17th, the first product was already ready to be sold in Brazil. The total submissions was 105 until today, which is March 31st, 2022. And the total of requests that were approved was just 16, and not necessarily are different products. The Brazilian legislation allows for the same product to be sold with different names. Now I will show you a chart. On this first column, we have the total of processes or products that are waiting for analysis. So they are waiting for analysis. We have just over 40 products in this situation. Just over 40 processes already had their analysis completed as well, and they already had a definition of approved or not approved. And around 25 or just over 25 are part in technical requirements. So we need to explain a little bit more about what leads to these processes to go into the technical demand or the ones that are not approved. And on this other slide, I can show you the completed analysis that are already made public, that we already published the results from Anvisa. In blue, we have 41% of products approved from the total of products that were already analyzed. In orange, we have 59% of products that were not approved, products which we did not approve the process. Here, I'm going to give you a quick explanation as to why these products are maybe not approved. Why were they not approved? Most cases for this one, it's not related to performance of the product. It's not related to sensibility, specificity, or how it can be repeated, or any tests related to performance of this product. Usually, these are related to usability, risk management, and use instructions. As I said at the beginning, usability is very important. Specifically, the manufacturer needs to call the product self-test. So that's the responsibility of the manufacturer. They need to be able to see and identify the errors related to the use. So the usability needs to be seen so that we can find whatever errors that they may have, like not reading instructions, not reading instructions correctly, or maybe getting the sample in the wrong place, identifying the test device where the sample is. If the sample needs to be diluted, where are the test lines? So the usability study is the biggest reason for why products are not approved. Use instructions are also another big reason for why products are not approved, especially when we have imported products and we translate the instructions. However, we do need to mention that the health policy, the national health policy, there are requirements that are specific for Brazil, like guidance in preventing COVID-19, our number to contact the health ministry to be able to guide people about the tests. So this information has to be on the use instructions. And also the language that needs to be simple and accessible, and it needs to be understood by anyone, teenagers to elderly citizens, with information for any type of social economical situation. So this is very carefully looked at by our technicians, risk management as well, and usability cases. So these are the main cases that lead to a not approval. I should also mention that Anvisa registering devices for in vitro diagnosis has an educational project. So all the yellow side, everything that was not approved, 59% that was not approved, all of this 59 received information. They all received information, whether they are a manufacturer or if they are importing things, they received their detailed reason for why they were not approved. So they could improve their request, or they could have failures or challenges that weren't done on risk management, and maybe failures or non-conformities other than performance deviations. And Visa as a whole has been showing that there is improvement in process quality in the submission of new products. So we hope that this number reduces and processes that are defined and that are according to that are more than the processes, than the general amount of processes. And as I said, in most cases, this is not related to the lab performance. So it's not necessary to have a design rework or a process rework for the actual manufacturing of the process or the product. But we need to be careful about the risk related to the user. We see the Power BI with the products that were regularized. So we can see all products that were done for COVID-19. We have a panel for the ones that are for auto test for COVID-19. And for all products, we have the daily update that is very transparent and very dynamic. So we can see that manufacturers and general population can follow the situation of the submissions if they are being done, if they're waiting for technical documentation, or if they're waiting for any extra things that Anvisa may have required. With that, we want to have transparency and agility for the manufacturers and everyone that is on the registry process. Thank you so much, and I am here for any questions that may come up. Thank you so much, Dr. Marcos Jucá, for this great presentation. Thank you for telling us Anvisa's norms about self-test and also giving us a general view of the tests approved in the country. Congratulations for the work you've been doing in Anvisa and for searching for safe and quality tests. So anyone, if you have any questions to Dr. Marcos, please ask your questions in the chat for the Zoom Q&A function. For the next round, I would like to call Cassiano Correr. He is a pharmaceutical, he's a doctor in internal medicine and the service platform. He's a technical consultant for Abra Pharma, which is the Brazilian Association for Pharmaceutical Networks. Dr. Cassiano, welcome, and you have the floor. Thank you so much, Pamela. Good afternoon, everyone. It's great to be here. Thank you so much. I would like to thank Carlos for the invitation and say congratulations to everyone and to all the panelists that came before me. They were great, really great. I want to share my screen with you. You can see that, right? Yes. Okay, so I'm going to have a view from the pharmaceutical point of view, like Pamela mentioned. I work with Abra Pharma, which is a Brazilian association for pharmaceutical networks. I also work in health technology, specifically with Clinicar, which is a health service platform for pharmacies and offices. And I'm going to give you the experience with the COVID self-test.
In the point of view of the drugstores, to give an overview, since 2020, since April of 2020, the drugstores are doing the COVID test since the beginning of the pandemic in Brazil. More than 4,000 drugstores providing the service for 2 years since Anvisa authorized the tests in the drugstores in Brazil. And this only in Abra Pharma, that's the association for the big companies. So we have more than 16 million tests in Brazil. And we have the images to remember about these people that were working there the last 2 years. And also the pharmacies, they have provided to the society, not only to the press, but the public opinion and also public health authorities about the behavior for the COVID tests from the testing being done in the pharmacies. We have a lot of weeks in a row that we manage and we monitor the results of these tests for antigen and antibodies. And this curve that I bring to you, it's a historical view since the week 95. That's the week that we are now. That shows a similar behavior to the waves that we have seen in Brazil. So this is an important thing that the pharmacies did in Brazil in the last 2 years. And we had some studies that were published last year. So when we had the Delta variant, we analyzed more than 3,300,000 tests done in the pharmacies in the first quarter of last year. Besides the information regarding symptoms that were reported by the patients in these pharmacies, and we published this, not showing the system and the different characteristics that the disease presented clinically as the population, the range of population, and also the quick tests in pharmacies. So this is the side of the pandemic that we know so far. For the pharmacies and the country, we consider that we are in the 4th generation of the quick test that we have started for the first the antibody, then antigen, and then for anti-spike antibodies, and now the self-tests. That's the topic here of our discussion today. The self-tests goes to the drugstores, as we know, and with the self-tests in the drugstores, in the pharmacies, and obviously we didn't have the end of the pandemic But we have this situation right now. The question is, in the practice, how can we help people? How can we help the population to get these tests and they can do the test in the proper way, can understand the results to do what they need to do. And I bring here what people are saying and how they're doing this. And we're talking about the beginning of this process once that the first self-tests of COVID in the pharmacies in Brazil, it has been for 3 or 4 weeks. So one side I'd like to highlight is that the same way that the pharmacists and the people that are there in the pharmacies, the health professionals that are there and they used to do, and they're still doing the tests, the professional tests of these patients, the same way the pharmacists are available for these patients that get the test there to guide them about the best use of the self-test and to highlight that the journey of this patient that gets a self-test, it's a journey that this person needs support and needs resources. Even though the self-test is simple, it is quite simple. It's important to have the resources available for these patients. And the patients, they're going to go through this journey and they will have some questions, especially in a country as Brazil, as we have so many difference in illiteracy, in socioeconomical points. So if there's difference between the tests, what to do if it's positive, what to do if it's negative, about the self-isolation, about the notification of the result for the people that this patient was together, and the use of self-test that's more indicated with a health professional. In some cases, self-test is enough. Looking at this scenario, an important innovation that we have is what we call the digital journey of the self-care. What does it mean? Once that this person buys the self-test, we understand that the journey of self-care is not going to stop there. We understand that it's possible and we need to do this. We need to create channels, to create mechanisms so the patient can receive orientation, can get the best information in the best format as possible to make the best decisions for their own health. What we have done is to create a digital journey that follows the physical journey, as we call. So in the box for the self-test, I'm showing here a specific brand, but could be other brands. We have a QR code, and this QR code we understand as a link, as a channel, which the patient can go through a digital journey. So after buying the test, this patient will read the QR code in the box with the cell phone, with the smartphone. It goes into an app, an online app that's for free, that's part of the service of the self-test, and they can be guided in this step by step of how doing this. I will show more details to receive personalized orientation using algorithms from the app according to the recommendations and protocols that we have from the health department in Brazil, and also give the opportunity for this patient to know what to do next. I will talk more about this, about having access to a physician and when the test is confirmed in the pharmacy. Going into details of how we can guide this patient, I brought here as an example to show we have some screens how this app works. So one side of this is like a label, and better than read a paper, you can be guided with images. We have different images showing what is the best procedure to take that test. We can see in this app what you're seeing there. If you see just one bar, if you see 2 bars. And the question sometimes from the patient, if it's the bar is a little bit lighter in color or darker. So the app can help this patient to see and understand this result, if it's positive or negative, and be able to ask to this patient if this patient has some symptoms, if it's an asymptomatic patient, and based on that, build scenarios to guide this patient. we've been used the name of result card to see that there's a delivery of this result, that the patient built that in the self-test. And this patient, once that has the result, he can storage, the patient can storage this. The patient can act, as we say, because after this orientation, the patient can go through self-isolation, can notify other people. The patient can share this result easily through an app, can share with the physician, with family, with friends, or even social media if that's the case, to say that the person took the test and what was the experience and what was the result. If the patient understands that needs another test to confirm, the app can guide the patient or to get a clinical paper to present or to go an event that needs to present this report. So this clinical report. So this patient can, on this app, find pharmacies close to the home where the patient can find this self-test, this antigen test. And in other cases, especially when this patient has symptoms, a more moderate case, and the patient is more worried, is not feeling well, and take the test and it's positive, the person can have a medical consultation, an online check. It can check with the physician online through the app. So what we are talking here is a journey, not only guide the patient to take the test in the proper way, but to understand the result and help this patient to make decisions of what to do. And this is an interesting experience. And we are in the beginning of that, a little bit more than 3 weeks that the first test started being sold in the pharmacies in Brazil. But we have thousands of patients that used this. The numbers are not completely available of how many self-tests were sold in Brazil. But regarding distribution, we have manufacturers that inform that more than 1 million self-tests were distributed. So probably we have higher numbers than that in the entire country. And as the population is using these self-tests, we can get all the data to understand what is the behavior of this patient in this self-care journey. What I bring to you of the first numbers, it shows the percentage of people that's using the online part, using the app, using the QR code of the box. So it brings the information that we can have here in a voluntary way. And we see that we have interesting distribution between men and women. So almost the same thing, 52% women. Of all ages, we have from 14 years old to over 80 years old. So it shows as self-tests can be more democratic because it doesn't have a specific age to use. And we have the states that have more people where we receive more results, so that we have more people using. It's the case of São Paulo state, Rio Grande do Sul, Minas Gerais, and Paraná in this order. Besides that, something that caught our attention, and the data that I will show, it doesn't have a epidemiological characteristic, is just it's a bias because I'm looking at the results that from the patients that use the app from the QR code. But it's interesting to see that the majority of these patients, they show positive results for this self-test, 79% positive. It's this rate, it happens in all states. As you can see in the chart on the table here on the right side, all the states that has a more relevant of patients reporting this. Obviously, is a biased result, but it shows a predisposition for the patients that have symptoms. So they look for help if the results are positive, and the app is something to support in the self-care journey. Besides that, going towards the end, I'd like to use the opportunity to provide something that from Abrapharma and CBDL that are building together that's related to the self-test initiative called myselftest.com.br. It's a website that will be launched in the next days. It's for general public, and it's a website that the goal is to inform, to have important guidelines how to use the self-test, what is it for, when to use it, and to help the population to find the reliable information in a fast way when they are searching this in Google, for example. But also this page from Abrafarm and CBDL, it's going to be something where we're going to have a link that the manufacturers of self-tests can inform the results that they are getting with these self-tests regarding the reports of the results. As we know in Brazil, from the RDC, about the information about the self-tests is something that the manufacturers will decide if they provide this for the patient to give the results and all of that. And the idea is to try to consolidate, to find a path to consolidate this information, to report this data to the authorities in the public health system of Brazil. And the test from the professional tests, they have this. So we understand that, so not just an individual data, but as a barrier to provide barrier for the virus, and also generate information that can be used for everyone. That's what I'd like to bring. I hope that I have brought important information to the participants, and thank you for the opportunity of being here.
Thank you so much, Dr. Cassiano. Your presentation was great. Very relevant. The contribution of pharmacies was very relevant as a health establishment working towards ending COVID. And an example of the innovations that were shown with testing in the digital world were very interesting and very inspiring for other initiatives. And it's more and more needed in this technological world. Thank you so much. Before we finish this panel, since our topic is from theory to practice, I would like to read something from someone from London. And this real life deposition really is really connected to what Dr. Rosanna Peeling brought at the beginning of the event. So this is the report. Having the antigen test to take at home allowed me to feel more confident to meet friends and family members, especially elderly people, knowing that with the negative test, the chance of transmitting the virus for my family members is very small. Other than that, having tests more frequently, regardless of the COVID symptoms, allowed all of us to do our part and contribute to reduce the spread of the virus. Having tests available at home made everything quicker and easier, giving us the flexibility of testing according to our convenience. This is something that we saw with what Mariana said as well, wherever I want, whenever I want, with people I trust. So to close, I would like to leave just a reflection on this deposition and how what we said in this panel and it's representative to all of us so that we can make sure that this is also something that can be said by people all around the world and related to other si- diseases as well, like HPV, HIV, HCV. So thank you so much. And now let's go back to Carlos. Excellent, Pamela. Thank you so much. I would like to thank Marcos Jucá and Cassiano. All the presentations have been very important and very timely as well to bring another view for the health sector. I would kindly ask Cassiano and Marcos Jucá to answer the questions in the chat as well as on the Q&A functionality. All of those who want to bring new challenges and new points of view, please do so. Unfortunately, I have to go because I need to respect our international speakers who are in Europe and they are actually 1 hour later than what we had planned because of the changes in daylight savings time. So I'm going to go to the next panel, what to expect from the self-test tool implementation in real life. So I'm going to invite Elena Ivanova, who is the
She's based in Geneva, Switzerland, and her work focused on emerging diagnostic technologies that has a potential to transform patient care in low and medium income countries. She has led research and development work in the fields of tuberculosis and hepatitis C diagnostics. She led groundwork in exploring potential of self-testing for hepatitis C screening, and since 2021, expanded her activities to self-testing for COVID. Helena is coordinating several projects at FIND on self-testing, spanning from early research to development work through product launch and demand creation. Helena, the floor is yours. Thanks a lot for keeping up so late for us. We do appreciate. Thank you.
Thank you so much. Thank you for this kind introduction, Carlos, and thank you so much for giving an opportunity to talk about our some of our past experiences and evidence that we have acquired in self-testing, as well as the some ongoing plans. Do you see my slide deck in the presentation mode?
Yes, perfect.
Okay, great. Yeah, so we have started the work around self-testing for COVID-19. We started more than 1 year ago. So it was started to conceptualize actually late 2020, and then kicked off some things in early 2021. And we initially structured the work around the three main pillars, which are technology development, because we right from the start knew that there is a great need, that we cannot do much without an affordable and high performant self-test devices. The policy development, so generate the evidence that would allow would support to the development of the relevant guidance, international and national, and market shaping. So there are all kind of activities around demand creation, and then piloting the introduction of the products in different settings in the countries. So I will talk very briefly about the upstream product development activities, and then more on the downstream product implementation parts. But briefly, so I've mentioned already during the first session that we've secured commitments from 4 manufacturers that are listed here on the affordable preferential pricing for low and middle income countries. So again, just to underline, this is the export price, meaning this is the price from the factory. It doesn't include the distribution margin, it doesn't include shipment costs and any relevant taxes. So the end price would be bigger than that. But also want to highlight that it's a maximum, it's a ceiling price. So meaning that if the volume are higher, or there is any special arrangement that can be made with the company, this prices could be and should be negotiated, and the discounted prices are very much possible. We also secured the volume commitment just to make sure that in case of spiking the demand spikes in high income countries where the company usually makes more money, that it doesn't, supplying this market doesn't come at the expense of the LMIC market. So there is a minimal supply commitment. So apart from the 4 tests, the 4 manufacturers that are listed here, there are 2 more that we cannot yet disclose the names because the contracts are not yet signed, but we'll be able to do it very soon. And then so you'll see that professional use versions of this test are mostly having the different kind of international approvals, and then some of the self-tests has received already some stringent regulatory approvals as well. So just to mention that the next step for us would be that we will be doing the evaluation of clinical performance of this test, and we'll be publishing the results of that on our website. So on the implementation experiences. So some of the early work that we've done last year, it was a groundwork on to understand the values and preferences around self-testing. So it specifically in low and middle income countries was well before the implementation of the self-test. The only exception is India, where the self-test was already implemented. But in most of the other countries, it was still a theoretical exercise when people were asked, were administered the multiple choice questionnaire, and then asked about which was asking about their perceptions and views and willingness to test, and then also a qualitative part when a subset of participants were invited for more in-depth interviews. In total, was more than 6,000 individuals included in the survey in general population across these 8 countries, and Brazil is one of them. And then we also asked healthcare workers about their opinions. There was more than 2,500 of healthcare workers across all the studies. So the results, there is a lot of data that we have collected through this research, but the key results I'm showing you here that first of all, we've seen a high willingness to use the self-test. The majority of people said that they are likely or very likely to use the self-test. And then the most importantly, when we asked people what would they self-isolate if the result was positive, they also absolute majority said yes. It's not here, but also we have asked whether they will report the positive result to the healthcare authorities if there is a channel for this reporting existing, and also more than 90% said yes. It was a bit less for negative results, so it's reflects that people think that it's much more important to report positives and perhaps less important to report negative results. Some specific data from Brazil. So it's those that I've just showed before. It was pooled data from all the countries. So in Brazil, we have the study was conducted, the survey was conducted in São Paulo, and the willingness to use was a little bit less than in other countries at that time, and it's probably because there was still a lot of hesitancy around the performance and then potential usefulness of the self-test. Just keep in mind, this was before the self-tests were implemented in widely in any of the low and middle income countries, and the policy was not existing in Brazil at the time. But however, it was the answers to the question whether people would self-isolate after the positive result was consistent with what we've seen in other countries, with a majority of people saying that they will. So people will do the right thing after receiving the positive results. Just very quickly on the willingness to pay. So in the data that we've received in Brazil, when asking people how much would they be willing to pay for the test, it was the answers ranged from 0, so only will use it if the test is free, up to $6 US per test. Very quickly on some key insights from the qualitative part. So there's a lot of, there was quite a number of comments highlighting that the access to self-testing should be equitable, and then the test should be quality assured, and then the should be widely available in the range of outlets and in the range of settings, including non-health related distribution paths. Such as convenience stores, kiosks, small shops, community organizations. So it was really highly valued by the participants. Guidance and support is very important. Also, participants have responded that there should be a very clear guidance on the next steps after the testing, but also an extensive education materials that would be building advancing the awareness about COVID and when to test for COVID, why to test for COVID, etc. So that was for the values and preferences survey. Another project that we've collaborated with our partners in Malawi and Zimbabwe with last year was the study to evaluate the feasibility and acceptability of the self-test in both rural and urban population. So it was what we looked at in frames of this study was how easy can people understand the instructions for use translated to a local language, and collecting their comments, what was easy to understand, what was difficult, what was which message is very straightforward and which is very confusing. So we've also observed people while they were doing the testing and collecting information about the mistakes and errors that they've done during the self-testing process. And also there was a qualitative part when selected subset of the participants have asked to provide some more in-depth views on the self-testing. The high-level conclusions are that the self-testing was highly acceptable, and the participants in both rural and urban communities in both countries can do self-testing correctly. It was a lot. Also, we've heard the comments from the previous study that it should be the rollout of the self-test should be coupled with the a very clear communication materials and a very clear message. Just to show you some data, so that's the usability, the percent of the people who didn't make any mistakes in any critical steps of the testing process. Just to clarify, even like a slightest mistake, which doesn't necessarily affect the test results, would count as a mistake here. But the majority of the participants have done the testing, all the testing steps without any mistake. But then, although there was some people who did some mistakes, it didn't really reflect on the performance of the test. So the concordance between the results of the professional use test and the self-test was extremely high, was 98% plus. We've seen no difference between the different age groups, and then we've seen no difference between the rural and urban population. Both populations have done the self-testing equally successful. We've seen some dependency on the age. So the elder the participant is, the more the probability of the mistake is. So that's another study that we've conducted over the last year. And now more on the studies that are in preparation and about to kick off this year. So this we've together with Unitaid Find has launched a call to grant to award the different organizations to conduct implementation research that would cover actually testing and treatment. And some of the organizations that have applied and were selected for the award had a significant self-testing component in their work. So those are the PSI-led consortium that many of you, I'm sure, know about from their HIV work, HIV STAR. There is a KNCV Orum consortium. There are colleagues from Fiotech, which I'm sure everybody here knows very well, and the partners from IS Global. So the most of the beginning of the year, the partners were planning and working on the protocols and the study concepts, and then we do hope that the most of these projects will start in this quarter, and we will looking forward to get the exciting results by the end of this year. So just to give a bit of a sense of where the projects are placed and what are the research objectives. So they are in South Africa, Malawi, Nigeria, Zimbabwe, Uganda, India, Ethiopia, Ghana, Mozambique, and Philippines. So it's a lot of countries all around the world, and it's different types of research, but basically most of them are focused on how to optimize the self-testing service delivery models. They target different populations, sex workers, workplaces, healthcare workers. It's both symptomatic testing of the symptomatic individuals as well as serial testing of asymptomatic individuals. So it's really different models, different populations. And we'll get a lot of very exciting data on how the delivery of the self-testing could be optimized. And I'm sure that this data could be very much useful for transferable to the similar settings in other countries, and would allow to scale up the self-testing in the most relevant settings. I'm looking forward to hear from our colleagues from PATH and Fiotech more about their work planned in Brazil, so I'll not speak more about this. And then rather I will just mention some separate set of activities that FIND is leading through a parallel project. So we've focused the implementation research in 3 countries: the country of Georgia in Eastern Europe, Malaysia in Southeast Asia, and we hope to also do several projects in Brazil. So Georgia is our most advanced country, where we already are very confident with what the target population would be. And we heard from the local stakeholders where the priorities lies. Malaysia, we're still in discussion, but we'll be we hope to have some clarity soon. And then we did have a lot of very useful discussion in Brazil, and many thanks to our partners here who really facilitated a lot of interactions and collected a lot of relevant information for us, but still looking forward to continued involvement and discussion, because we do want to hear your thoughts on what should we focus on here. So we are still in the planning phase, so it's really a right time to discuss further, and we really look forward to that. Basically, yeah, I can skip this slide, but go to the really the approach. So we started with doing some landscape research, and meaning that doing some desk research, understanding the status, the current status of the policy, and some whatever published information was, and then moved to interviews with some key opinion leaders in the country, and then where we're currently in is to identify the target user segment population, target user segments where we would which would be the most which would benefit the most from the self-testing. That's what where we are at, trying to define which together with the partners in Brazil what are this target population. Once that is defined, we will move to the formative research, and that's really important. This is really when you are getting a lot of community insights of how the self-testing service delivery should be established and set up in this community. This is extremely important to get the feedback from the people who would use the test, and that to ensure that the model that you are conceptualizing and designing is actually something that is useful, is convenient, and is safe and is acceptable for the people who would use that. And once this formative research stage is done, that will be ready with the implementation pilots, hopefully in Q3 this year, and will that would allow us to gather the data about how to operationalize the self-testing, how to make it the most cost-effective, and how to establish that as a sustainable intervention. I think I've covered that, and then that's what I wanted to share today. Thank you so much. Would be very happy to answer any questions within this webinar or outside. So please do feel free to reach to me or my colleagues, and happy to continue the discussion. Thank you.
Thanks a lot, Elena. It was great. I think you brought a very fantastic insight in order to give us clarity on the ways to go, and always having in mind that we are going beyond COVID. Self-testing can be an interesting tool, and I think you have shown that we do have a good journey to follow and bring the best possible result. If you don't mind, I would like to call Emily Gerf-Guyet and Délio Pereira also for the next presentation. And any questions to Elena, please, you can type at the Q&A. And at the end, if she's still available, then we can have some answers. Emily is public health researcher in the diagnostic group at PATH, working on diagnostic performance and operational research studies, primarily in malaria and other infectious diseases. And Délio is clinical director and researcher at CPEM here in Brazil. Please, Emily, you have the floor. Thanks a lot for keeping up so late as well. Thank you.
Yes, thank you. Thank you very much. And actually, today we're going to present a little bit about two studies, one completed and one that's what we're currently planning, both in collaboration with CPEM under Délio's leadership. So I'll actually pass to you, Délio, first to present on the diagnostic study we completed last year.
Okay, thank you, Emily. Thank you, Carlos, for the opportunity to present this first results of the study, and later on the partnership with PATH that will be the next project. So the first one, okay, yes, is here was we call it COVID DX. This assessment of viability of point of care testing for SARS-CoV-2 in asymptomatic individuals. We have a partnership with some institution here in Brazil, that's CEPEM, Fiocruz, FMT Manaus, University of Washington, Global Health Strategies, PATH, and Rockefeller Foundation in Amazon. This study was conducted between July 6th and September 29th, 2021. Was a prospective diagnostic accuracy study was conducted in Porto Velho, Brazil, in collaboration with the Centro de Pesquisa em Medicina Tropical de Rondônia. It's that's called CEPEM. It's in Rondônia State. It's the base Amazonia Basin. These studies aim to evaluate the performance of diagnostic tests for SARS-CoV-2, designed to enable point of care or decentralized testing approaches, also enable a greater understanding of trade-offs in testing selection to inform screening strategies regarding the timing and frequency of the testing and performance characteristics. So we do have here, let's see if I can, that's okay, I can move here. Okay. Okay. This study was a prospective diagnostic accuracy study was conducted among close contacts of COVID-19 positive cases in Brazil. 3 rapid antigen tests and 1 molecular method were evaluated against reference for RT-PCR on nasopharyngeal swabs. 2 anterior nair swabs, that are nasal ones, nasopharyngeal swabs, and saliva were collected at all visits. Vaccination history and symptoms were assessed. Household contacts were followed longitudinally. In total, 50 index cases in 214 contacts. Among those, 64 households were enrolled. 65 contacts were RT-PCR positive during at least 1 visit. Overall sensitivity of evaluate tests ranged from 33% to 76%. Performance was higher among symptomatic cases and cases with CT below 34 and lower among oligo or asymptomatic cases. The 2 rapid nasal antigen test, the standard Q nasal and the Lumira DX, demonstrated comparable performance, which was best among cases with CT below 34, with sensitivities in the range of 90% and 60% for symptomatic and asymptomatic cases, respectively. So this last slide for this study shows the time to positivity from time of first visit for close contacts with a positive nasopharyngeal RT-PCR results with CTs below 34 at any time. To help you, that blue line is the proportion of nasopharyngeal RT-PCR positive case identified as positive by the point of care antigen test, the standard Q COVID-19 antigen test on nasal samples. The green line, those identified by the reference nasopharyngeal RT-PCR. We call attention for the box, the 3 boxes in the right, that show interesting results that even with a relatively rapid test, RT-PCR results turnaround of 24 hours, more than 70% of the contacts would have been identified by the point of care test. At 48 hours, accumulative sensitivity is 80% and increasingly near to 90% at 4 days. This is important because the turnaround for PCR in most of places is not around 24 hours, it's more like 48 or later on. So the point of care test for antigenous one, this brings a lot of information earlier than the PCR. So the next slide, I pass it to Emily.
Thank you so much, Delio. Yeah, so building on that study and you know, having the opportunity to continue working in Portobello, we started thinking early on about how this contact tracing platform that was established could potentially be sustained, or continue thinking about ways to use it beyond the close of the study. And you know, at the same time, we started thinking about the questions of self-testing use cases, you know, as they were moving through the relevant policy and regulatory processes in Brazil. And I think, you know, one thing that was really coming to the front of these conversations was that self-tests were available in Brazil, but through this pharmacy system and at a price that might be difficult for everyone to have equitable access. So the thinking was to really try and integrate self-tests into a public health system in a way that showed how they can be used, which really aligns with the overall aims of the STAR project that Elena mentioned earlier, which is just really looking at the operational system delivery strategies for self-tests, and what are those delivery strategies that can maximize the benefits that we've all been talking about and minimize some of the unintended consequences, which have been highlighted by other speakers. So the following slides, I'll just walk through the follow-on study that we have planned for later this year, where we're really trying to show if and how these self-tests can be integrated into a contact tracing system. So we're going to be testing the effectiveness of a serial self-testing strategy. So testing up to once per day for up to 10 days, and how that can support the public health contact tracing program in actually identifying positive cases. So our theory of change is that we can actually reduce the burden on the health system, on patients, and on providers, and get more testing data per potentially exposed individual. In this study, we'll use antigen rapid tests that have been approved for self-testing by Anvisa, and we'll be giving self-tests to both the close contacts of confirmed positive cases, and we will be monitoring their use of the tests through remote data collection. So the objectives of the study are really wide-ranging. The primary of which is actually to evaluate the effectiveness of this service delivery method, looking, you know, ultimately at how many additional positive cases can we identify in the group that does self-testing as compared to the group that does more traditional contact tracing with either just testing at one point in time or potentially no testing at all. We'll be looking at a number of measures of the operational feasibility of self-testing, including the usability of the tests, looking at the concordance of a supervised self-test that's conducted at enrollment as compared to a professional antigen use test that's done by a trained health worker, again, at the enrollment visit. We'll be including some qualitative methods as well to explore the barriers and facilitators at both the provider and patient levels that may impact the success of this intervention. And then we will also be looking to generate supportive resources, much like the digital tools that were spoken about and some of the other user-friendly instructions for use. to include either that are test specific or maybe test agnostic that will support self-testing and implementation. We also have a few more exploratory aims. We'll be enrolling close contacts through a positive index case. And so we're going to follow those index cases as well remotely to understand how they're adhering to public health guidance for isolation over the course of the study. As that changes, I think we've already seen it change and reduce the number of days in Brazil and in other geographies. One of the things we were really interested in was looking at more like voluntary at will use of the tests, sort of without someone having to be consented and enrolled into a research study, which the primary context for the study certainly will be. So we're going to reserve an additional subset of tests to give to the household members of study participants who can use the test at will and report data in an anonymized fashion. As I mentioned, one of the objectives was around these supportive resources. So to generate those, we'll be conducting usability workshops, which look at how the training and instructions for self-test can be optimized for our target population. And then to just sort of help us triangulate self-reported behaviors against a second measure for participants who consent. We will be looking at GPS data to help triangulate how they report their isolation and quarantine behaviors against what that data shows. And then this is finally just the study overview diagram to show kind of how we intend to look at these three distinct populations. So, our primary participants of interest will be the primary exposures, the close contacts of confirmed positives, and they'll be enrolled into one of two arms, the first of which will be more similar to traditional contact tracing, where they just get a single test at one point in time, the sort of municipality standard. And in the second arm, participants will be enrolled to receive, to first complete a self-test under supervision with a healthcare worker, and then next to take self-test home with them and to conduct them over the next 10 days. And then, as I mentioned, we'll be looking also at the index cases and at a bit more of a distance, what people who are given tests but not formally enrolled into a clinical study, what they would do with the self-tests if given them. Okay, next slide. Yeah, so what do we hope to show or achieve with this study? I think primarily to understand if this is a viable strategy for integrating the use of self-tests into a public health service delivery program. And, we're hopeful that this could be a testing strategy that worked in both periods of high and low transmission. So I think, as the waves of the pandemic have come and gone, we've seen a huge establishment of testing services, and then they'll shrink when cases go down, and then they're needed again when tests come up. So, one of our hypotheses is that this could be a way to maintain one method of test availability without those big infrastructure changes. I think we're going to look closely at what operational guidance is needed for municipal health systems to actually implement this intervention, including what to do around the results reporting. And then finally, it'll be another piece of evidence that shows how tests, the performance of self-tests compared to the approved professional use antigen test at one point in time. And yeah, that's it. I'd be happy to answer any questions, comments, either now or offline. Thank you very much.
Fantastic, Emily. Please count on our support locally for whatever is needed for this kind of study, CBDL, Aladiv, and our partners locally. It's going to be a pleasure to support and evolve with this kind of investigations for future use of even other kinds of self-test. I think it's quite important what you're doing. I would like to ask you both if you can remain a little bit more, and then invite Thais Aranha from Fiotech to have her presentation, and then we open for questions and discussions after that. Would that be okay for you? Yes?
Sure.
Thank you.
Ok. A Thais Aranha Rossi é professora da Universidade do Estado da Bahia, UNEB.
Thais Aranha Rosa, she works with the Bahia University, the Federal University in Bahia. She has her doctorate in Sun European for sociology and political sciences in Paris, and she's a permanent teacher in UNEB. Thais, welcome. You are welcome to start your presentation. Thank you so much, Carlos. Let me start sharing my screen. Firstly, I would like to thank you for the invitation. Thank you for the organization. Congratulations for this event. I would like to present a control and, well, what we are working with in the protocol phase. This highest protocol, which is on the strategies for testing, quarantine, e-health, telemonitoring, and how it can contribute to the fight against COVID-19 pandemic in two Brazilian capitals, Salvador and Rio de Janeiro. And they actually have a lot of institutions that are participating in this project. The Federal University of Brazil, Fiocruz with the Infectiology Center, UNEP, the State of Bahia University, and the postgrad programs, and also the Federal University of Rio de Janeiro, but also the participation of the Health Secretariat of Salvador, Rio de Janeiro, the World Health Organization, FIND, and Fiotech itself, and Unitaid, Unitaid. This protocol that I'm talking about has components that I'm not going to specifically talk about because our focus today is the self-test, but it's important to mention that this bigger project has a central component of implementing testing, self-isolation, self-test, and the second component related to comparing performance of two rapid tests, two antigen rapid tests to detect SARS-CoV-2, and also another component related to new variants of virus SARS-CoV-2. And this is the component that I'm going to mention here related to acceptability and usability of self-tests for COVID-19. It is important to mention that this study is coordinated by Dr. Inês Dourado, Dr. Vadilea Gonçalves, Dr. Vadilea from Infcruz, and as co-PIs, Professor Laio Magno, who is here with us. I'm also co-PI, and other researchers, Marcos Benedetti as project manager, Dr. Beatriz, and other investigators as well that contributed to this investigation. The goal of the project is to assess the acceptability and usability of COVID-19 self-testing among people from high social vulnerability communities in Brazil. And they are covered by the family health structure that I mentioned in both capitals, Salvador and Rio de Janeiro. In Salvador, in one sanitary district, and in Rio de Janeiro. It is a cross-sectional study that will be conducted on the population I mentioned from these two highly vulnerable cities, following inclusion criteria of individuals aged 18 years or older, and they will be recruited from both communities mentioned in component 1. So this is a protocol that has other components, and component 1 that we call TQT in Portuguese. There are some subcomponents that are related other than testing with the antigen rapid test isolation, quarantine, and telemonitoring with vigilance, support to the work process, and monitoring this entire process that is being created, active searching, procurement for this test, including managers, staff for the secretariats of these cities. A digital platform that integrates the system, articulates vigilance, and gets a legacy that goes beyond COVID. We are looking for learnings. The included participants will need to be literate because they need to be able to read in Portuguese. It will be a purposeful sampling with 240 individuals, and they were selected because we want to have big diversity of the Brazilian population. So color of skin, minimal 50% having Black people, gender, age groups as well, young, old, and elderly population are included. Participants will be invited to participate in the research by a team that is trained in research, by community agents that work with health, considering that this study also wants to support the Brazilian public health system by professionals who are already working on primary care. And before the self-test, these participants went through an interview. They went through an interview by the researchers with a questionnaire about social demographic data, previous experience with COVID testing, and COVID itself, and also acceptability of self-test. After that, these researchers will, in another room, observe the performance of the participant related to the self-test performance, and they will record it on a specific form with a specific script to follow. So they will receive a self-test kit with the manufacturer, with all the information that comes with it, and there will be no interference in this process. So a trained researcher will observe and record the entire process for all the steps, registering if there were mistakes, confusion, what were the challenges, what were their mistakes, with no interference in the process.
There will also be a presentation for this participant of the devices, of the negative, positive samples that were reactive, weak, and valid. And then after 15 minutes, they will interpret their own results. And we have the duration of this study. The expected time is for 3 months. With quantitative instruments, as I've mentioned, have different social demographic information, experience with the COVID-19 testing, and qualitative, and trying to find the register of these researchers for all the process that's being done regarding the self-test. And we will have dimensions related to the prepare for the test, the collect of the nasal sample, the performance regarding the test, the interpretation of the result, and also the general observation regarding the process of the test. And these instruments and the consent forms will be applied by a trained research team before the beginning of the entire process of this study and for the questionnaire. And what is the step that we are now? We have the local approval, the Fiocruz approval. We are waiting from the approval, the ERC from WHO, so we can move on with the data production, data analysis, the scientific publication, the technical production. That's trying to have a language that can support the decision making of the local managers, the national managers, and from other countries too. So we expect to contribute to increase the access to the diagnosis of COVID-19, to contribute with the reduction of the spread of SARS-CoV-2, the knowledge on usability about the COVID-19 self-testing, and also provide evidence for the decision making, as I have mentioned, for the self-testing for COVID-19. And also we highlight the importance of the study about being a population of communities with high social vulnerability in these big cities of Brazil, Salvador and Rio, with a population that has a lot of times, the majority of them cannot buy this self-test. So we highlight the social impact of the study regarding this and communities that that are in high social vulnerability. This is what we want to talk about. I'm available here if you need to ask questions. Thank you very much. Great, Thais. I think that was your presentation was quite important to show what we can bring as conclusions and also be prepared for a next pandemic in a faster and more dynamic way. I would like to invite Elena, Pamela, who else? Rosana and Claudio, Mariana, for you to open your webcams. And if you want to make comments about the presentations, and we can go to the final questions and final presentations and maybe your conclusions or final remarks. I know that all of us, we have a lot of things to say, to share, and I thank you all for participating. Claudio, please. First of all, congratulations. Thank you for inviting me, and we comment about this, and this was in a lot of the presentations, that we are going through a shift in the paradigm, the technological point of view in the healthcare with more autonomy for people. We're talking about a specific case here about COVID, but I think that's a huge set of diseases and follow-ups that should be present in our future. The image of a different way of people to relate to that, to the service and the health service and the relationship between the health services. And Rosana mentioned about the challenges, about the production, because we can have other pandemics, and the need to have production lines that are more flexible, that can easily change the type of agent that's being used, especially when you have more experience of fast tests that are not the self-tests, but quick tests in the approach about other syndromes when we have streptococcus and some other respiratory virus. And this can help a lot, not only for that health professional that are in the health service, but people in an autonomous way when they have good information. And we have something important here that's not being explored enough by the public health service, and the access to support services. Maybe you should think in a new service model that's the integrated service as a support with the self-test. I mentioned before, I think that not about the cost, but the price that it goes to people. It's a relevant topic. Even think that this price can go lower. I think that's hard to have we need to have an expansion of these technologies if the government doesn't participate with public systems to provide that, at least for the situations that are a priority and for those people that are a priority. So thank you, congratulations to everyone. I really enjoyed the presentations. Great comments, Claudio Delio, please. And I think that we should bring the point about the studies that we are working with, studies related to the point of care, the self-test, as we have seen. And in the world, we have seen other technologies, molecular technologies as a self-testing. United States have launched some, and also the information technology related to other solutions. So Delio, if you could, Thais, Emily, and Lena, to comment a little bit about this. The focus now in big volumes, low cost, accessibility, but without the other parts that are going to be more accessible. I will talk in Portuguese. What we have learned a lot with COVID is the dynamic of a new disease, and it's changing the technology for diagnosis, policies, the organization of the public health and public policies and treatment. This is quite dynamic and really fast. And what the majority of people are talking here is the important role of bringing awareness for the population, for the health system and the policies or the people that will decide about the laws. More than talking only about marketing and mention the quality, the goals, the usability of a self-test or antigen or molecular or something that will come. Maybe it's more about the branding to say what is the value of that for people to understand how important is this to be an instrument of daily use for epidemiological health system. And today we have discussions in Brazil talking about the end of the pandemic is not something that not one country will decide, but if it's endemic, if it's a pandemic, when it's going to change. We don't have important numbers yet as a control diagram to define how it's going to behave, if we have an outburst or not. So there are a lot of information that's missing. And this is going to impact of how much is going to be produced, what is the policy that's going to be organized as in sectors as a model. Is it going to be as influenza that we had outbreaks and it's there for a while, and then we have inputs for a period of time? Are we going to invest in vaccine or in tests? Because we are talking about similar syndromes, so tests that will be developed together. The importance that we didn't go deep on that about choosing the treatment. We talked about the previous treatment about medicine that we couldn't work with that, but we have new drugs that will work as it happens with influenza, that we have a window to start a treatment, an antiviral medicine, so for 48 hours. So the early diagnosis with antigen or point of care, it's quite important for that. And another topic is the access to that regarding the cost and the distribution of that. Sometimes in rich countries that they can buy that or the population can buy that. But the logistic to take this material and how to have access to what later, the treatment, the isolation, a lot of things needs to be learned. I congratulate to all the groups involved here that we have field works, we have investments on that to make the decisions based on evidence. I think this is my final remarks. I'd like to thank you all for the opportunity for listening to all of you.
Would you like to make any comment? I am really very sorry to keep you so late, and it's my fault, I promise. On the 7th, we are going to have in Brazilian morning, so it's going to be easier. But I owe you one, so please feel free, from all my gratitude, feel free to make any comment.
No problem at all. I really enjoyed the meeting, and I really don't mind to stay late for a good cause. Yeah, no, I was. I feel it was a lot of very useful discussions, and there is. It does seem to me that there is. We do have a very useful guidance from WHO now. It is. And as WHO colleagues have outlined, this is now to the countries to understand how to better use it and how to better implement that. And this is some of the things perhaps could be you could model, or you could imagine, or you could calculate, and you can say, well, based on my theoretical assumption, this or this does not work. But then some of the things you need to go and then and try and go back and redesign and try, and it's worth it, because it makes the intervention sustainable. So you don't do something that is not workable. And honestly, this is what we've seen in high-income countries, where the self-testing was implemented more or less in the panic mode when it was on the rise of the epidemic waves, and so it was a lot of decisions were taken, and we have the means in terms of budget, so we have to respond to the pandemic in the fastest way, and there was a lot of lessons learned there, how to. That would allow us, that actually going through that mistakes allow us now to think how to make it better. Now when we can be more cold-minded and more have a more common sense and planning in hands, and then use the self-testing not in a panic mode but more in a smart way. And that was, at least from my perspective, is also targeting those population that would benefit the most, and those who perhaps would not be tested otherwise, right? And I'm sure it is context specific, and it might be different from country to country, but it's paramount to identify what are the priority populations and how to make the self-testing easy tool for them to use. And then last but not the least, how to make sure it's not just, we are not going and trying things that would not be taking, that would not have funding afterwards, right? So we've talked a bit about the private and public sector, but if you make self-testing accessible only in private sector, I don't think you solve this equity problem, right? So it still would be a tool for rich and middle class people, would be accessible to those in need. So figuring out right from the start the ways of how to make it sustainable, at least for some selected population, securing international and domestic funding, for me, that is one of the most important aspects. Thank you.
Perfeito. Thais, por favor.
Thais, please. I will done the final remarks. I would like to thank you for inviting me, to thank the organization of the event, everyone, and what we have asked about the research in a dynamic moment that's the pandemic, and we are going through this perspective to study something that's happening, that's dynamic, and trying to create evidence that we can use to make decisions. So I think this is what we're trying to do. So again, I'd like to thank you for the opportunity, and I'm here.
Excellent. Great.
Points. And Rosanna, you are the best one to make very nice conclusions. So be our guest here.
Thank you, Carlos. It's been such a rich range of discussions. I really thank you, for designing the program so that we could hear. Because even though I participated in the development of the WHO guidance, hearing how complex it is to translate the guidance into country guidelines and strategies is very useful, because every country has its own limitations in terms of resources, where are the needs, etc. And I especially when we were developing the guidelines about workplace testing, and we said it should not be coercive. And yet I know in many countries where if you're a healthcare worker, especially if you're a part-time health worker and who test positive and had not, cannot come to work, then you lose your wages, and who's going to support your family, right? In a lot of countries, they have wage subsidy. If you lost your job due to COVID, you are reimbursed for your salary so that you could continue to support your family. But in many countries, that's not the case. And so I think, translating WHO's guidance to say, okay, no coercive workplace testing, that's a difficult thing for a lot of countries. And then other issues in terms of vulnerability, getting to marginalized populations, making sure that the access is equitable is also a real problem. But I think beyond that, we need to think of what we're doing as being very useful for the next pandemic. Heaven forbid there should be a next pandemic, but there may be. And we know that epidemics are happening more frequently and with more severity. So there will be pandemics. And so even as we are struggling to figure out for, say, the next flu pandemic, what should we do? We've never advocated for individuals to get flu testing because there is no time to intervene. Flu just comes in, it's very efficient, and goes through the population very quickly. So that's why we always say the strategy for flu is not testing, is to say, if you think you have the symptoms of flu, stay home so that you don't infect anybody else. But now would we say, if you think you have flu, go get tests, go get a self-test and see whether you really have flu or not, and stay home if you have flu. So especially if you're a healthcare worker or you work at care home, maybe this is what we need to say. And so these things need to be worked out, and whatever we're doing here would be very useful to inform that kind of future policy for the next pandemic, next epidemic. And then in terms of what Claudia said about, other syndromes like respiratory infections in general, we should think about self-testing in sort of a broader aspects of it. But then beyond respiratory infections, I'm thinking of the self-test that we always wanted to prevent the risk of antimicrobial resistance, which is the simple rapid test to distinguish between bacterial and viral infections when somebody has flu symptoms or respiratory symptoms, because we know that there's a lot more antibiotic prescribed for respiratory infections than there should be, because most of it is viral. And so we've asked, we had a lot of organizations have funded to have a simple rapid test that could at least distinguish between bacterial and viral infections. And that should be one that parents use at home to test their kids, right? And so all this groundwork that we're doing would really inform, if that test come to be, how we would use it. Because for antimicrobial resistance, we know from the latest Lancet publication that even though the Jim O'Neill report said by the year 2050, there'll be 10 million people who die of AMR-associated infections. Well, in the latest Lancet publication in 2019, there are already 4.95 million people who die of AMR-associated infections. So the crisis is getting worse than we ever thought. And so we need to be doing something about that. And I like to think that this work would be very, very helpful for us to think about the self-tests for AMR that we need. So thank you very much for this opportunity to think through all these. Thank you.
Thank you, Rosanna. Thanks to everyone that has participated today and has actually been fighting against the COVID, bringing so many nice ideas, so much effort, and that is going to leave a very good legacy for the future, for the next generations. And to talk about legacy, we're going to have on April the 7th, another seminar, another webinar. And the idea is really to bring perspectives of testing expansion, then to talk about the WHO and partners through the ACTA diagnostic and the legacy that we are going to leave. Many of us here are taking part in this program. And finally, within the Brazilian environment or scenario, we are going to talk about the last battle, how to keep COVID-19 away. And it's going to be a very nice discussion led by Gonzalo Vecina, the first president of Anvisa. And we are already with several members of the different areas like industry, Anvisa, labs, pharmacies, and healthcare professionals already participating. They have confirmed participation. So it's going to be in the morning in Brazil. So it's going to be easier. And I count on you. And all these discussions that we had today are going to be part of small releases or even papers that we can promote through London School of Hygiene and Tropical Medicine and IDC, through FIND, or for all the ones that can and could use this to leverage the concept of early diagnosis as effective as possible, exactly to bring more health to the people. So thanks a lot. Thank you to the translators. I know we have been giving a lot of hard work to them, and to all of you that have been so far with us. Thank you very much and see you soon. Thank you.
Thank you. Thank you. Bye.